a large chunk of land. So we really want to make sure everybody's understanding that and can answer any questions. Then we'll do administrative services and the business unit, economic support, behavioral health. We'll give you a break. Then we'll do children and youth services, public health and nutrition, and then the ADRC, and we'll do a tour in the end. Oh, geez, sorry.
That's all right. I know you did. I did come up on your side.
Go to the next one, Jamie. So now we're going to just talk about the services, just a brief overview, and really talk about which ones are mandatory. And on this next slide here, first we have the child welfare services. So that's child protection, abuse investigations, foster care and institutional care, reunification services, and termination of parental rights. And Jessica will talk a lot more about those, but those are mandated by the state that we have those services in place. Next is our juvenile delinquency. Jessica will also talk about those, but it's really services to rehabilitate the juveniles and protect the community. Our long-term support services, our disability benefits specialist, resource center, eligibility determination for managed care, and children's long-term support waiver. So those will be discussed by both Roxanne and by Miranda. Our birth to 3 will be explained by Miranda. Our aging services will be both Rose and Roxanne. Mental health and substance abuse services will be by Miranda. Economic support services will be by Brianna. And one of the things that I really want to stress with the economic support services is we do have 15 workers in that unit. We pay the exact same amount to be part of the consortium, whether we have 5 workers or 15 workers. We have a maintenance of effort that we have with the consortium that no matter how many workers we have, we pay the same amount. The rest is then covered by the region. And then we have our health department, and we'll have Rose come and talk about that. So all of these services are mandated for us to provide to the residents of Richland County. That's just our org chart in very brief. Angie will go over more of it in, as time goes on, but we'll have somebody from each of those units talking about what their unit does.
Right.
Switch when we get a chance. Okay, so then our last few slides are just really for some of the resources to learn more about us. The first one will be our website. Oh, on your iPad, you can find the HHS/Veterans Board meeting materials. So there's information there on all the different board meetings. Our next one is our website, the Health and Human Service website, and the last Facebook page. And then the last thing that I want to say before I let all the managers take over is that if you have any questions, please feel free to ask throughout the meeting today, but we're also willing to come in and sit down and meet with people one-on-one. So if when the day is done, you really are like, I don't really understand how the behavioral health unit goes, can I come down with you? Miranda and I, and along with Stephanie, would love to just sit down with you and answer any questions that you guys may have. So we will first start with placements. And like I said, that's a big part of levy that we have involved in our budget is the placements. And I'm going to have both Miranda and Jessica talk about that, talk about how that works, keeping in mind that these are mandated services for us to provide. Scroll. Oh, sorry. Yeah, it's not up.
So good afternoon, everyone. Just a little bit about placements. I know I've discussed these in board meetings before, but it never hurts. It's a complex array of funding and requirements that gets us to placements. So just understanding the placement types, class, and mandates. A couple important Principals, when we look at the placement reports that are in your board mailouts each month, information about each placement is limited because of the need to protect client privacy. And we can't answer any client-specific questions. So you'll see bars on the graph that represent each client, but we can't ever divulge who that client is or information about the individual patients. The majority of placements occur with a court order or under court oversight. So those two areas that are covered are typically for adults, either adult protective services guardianships and protective placements, or Chapter 51 commitment orders. Some placements may occur voluntarily in order to manage safety. I would say just statistically, that's going to be well under 3% of our county placements. We don't use those very often. And, by far, the majority of individuals are under court orders, if not all. All placements are required to be provided in the least restrictive setting necessary to meet individuals' safety, treatment, and/or care needs. And then Health and Human Services is responsible to manage each placement to assure the appropriate setting or level of care is provided. Just a little bit about the placement reports. Adult placements, or Fund 54, are shown on one side of the page, and child placements, or Fund 44, are shown on the other side. Placements on each page are divided into two categories: the institutional type and the community type. Types of placement facilities and the cost range are shown in each section. The chart shows a different color for each person who has been in a placement. And the same color in the chart represents the person continuing or returning to the placement. The table below each chart shows the total days of stays for each month, total number of individuals and placement for each month, monthly costs of all placements, and then any reimbursements that were received or credited, the county's expense for the placement.
Go ahead.
Can we ask questions?
Yes.
So I didn't see that in the annual report.
So it isn't something that's in the annual report, but each month we provide those to our committee meetings and to our committee. We just really wanted to let you know how we're reporting it to our committee and kind of how this process works and understanding the types of placements that we have.
So on the Fund 44 page, which is the child institutional and patient, those are grouped along with secure detention and non-secure detentions. In that first chart, so group homes, treatment, foster care, and regular foster care are grouped in this chart and separated out on the tables. Each of the tables are again totaled beneath with the cost, the reimbursements, and then the total county expenditures that are shown at the bottom.
Can't really read those in a way,
Mhm.
at least I can't.
Not in this.
I was gonna say, I think in the format that they're provided in the iPads on a monthly basis, they do show up on a larger page.
But if we go to the on our iPads to the committee, the HHS, those reports are there, I can go back and look at them.
Yes.
Okay, all right.
I think we're done with that page.
Yeah, so this is just in a little bigger format. It's the Fund 54 for institutional type placements, adult institutional and inpatient stays. And just to talk about that definition a little bit more, it's our emergency detentions that go to Winnebago, and on occasion there'll be overflow to Mendota. And then our crisis stabilization funding also covers some of these placements in the care centers through a contract with Tularian. So again, the Fund 50 for institutional type placements include the mental health institutes, Winnebago and Mendota. The cost range for these actually is between 1,039 and it's actually up to a little over 1,400 a day. That figure was from an older presentation. It's a little bit more than is noted. Reasons for placement, again, emergency detentions and long-term mental health treatments needs. So if someone is unable to care for themselves or be safe in the community, those are reasons those placements would be used. And then different reimbursement sources include Medicare, private insurance, private pay, and then of course the Fund 54 placements do fall to tax levy.
So if we had a person in Winnebago for a year, what would it cost us? Someone do the math for me quick. And usually they're not in Winnebago. for a year.
That's not a time frame we would
not real
typically
estate,
ever
right?
fund, but. Yeah, I was gonna say about 700,000. I was low. My math isn't that good. Clearly, of 511,000. Yeah.
So of that amount, how much are we as a county responsible for, as opposed to the state who's mandated this? Do they provide funding?
100% the county
I'm
is,
sorry,
the county is 100% responsible for it.
and do we get any state money to help defray that cost?
We do get state dollar. Yeah,
And this
for mental health
is a very
services.
big expense.
Yeah.
And I'm wondering, why the state may be dragging their feet when they say, you gotta do this, and there's no money. I mean, financially, we're in a predicament. And my guess is that this is a piece of it.
I think one of the things that the state thinks is, instead of giving us money for the placement, and you can correct me if I'm wrong, they are gonna give us money to prevent placements. So they'll give us money to fund different programs, to provide community supports, to provide mental health, AODA treatment. So that's where they're giving us the money.
That's a wonderful thing where you can stop this. But once these things happen and we're kind of having to bear that expense, that seems to me to be something that should go beyond the community, that, the state is trying to usurp a lot of money from various municipalities. Well, if they're gonna do that, they should be responsible for the other also, in my estimation.
Yeah. And I can't disagree, but this is, at this
Is there
point.
any way of getting the senator or representatives that we have that kind of sit around in Congress and collect money that they can actually work for us?
We certainly can share this information with them and make sure that they have an understanding, because they probably don't.
Yeah, well, I think they.
You don't have to answer that.
Okay.
Need a Frank. in our hand.
He's being,
Deal with them.
he's being rhetorical.
I am.
But what Tricia said, explained, I think it answers Marty's question earlier, what would this person cost if they were in there a whole year? Because we have all this other funding and we're able to work with those individuals to make those stays short. That's how we're able to not be able to not spend $700,000. I think 1 month was fairly high, but I don't know that we've ever really had anybody in there for even 30 days, sadly. Not recently anyway, not recently, but it has happened.
Yeah.
But the work, but like I said, the money Tricia says we get is to get them out of there as quickly as we can. So.
Part of Director Thorson's emphasis in the past 2 years has been, or longer, has been to shift the institutional placement into community-based
Right.
that is covered by the state.
With this tree.
So how can you comment? Maybe you're going to on that
Yeah.
as we go.
Well, and I can talk about it a little, I think future slides will lead to it as well. So, those funds that the state has made available are through what's called psychosocial rehabilitation, placing individuals in community settings with support such as adult family homes, or the care center that I talked about, where there is some reimbursement through health insurance to cover those placements. So I just want to touch on the other institutes for mental disease. I think that was the slide previous. We don't use those type of placements a lot. It is a resource if needed. But one of the reasons we don't use them a lot is they aren't reimbursed through insurance, but it is a good resource for an individual if they would need a long-term stay. Like for example, for individuals that are having challenges getting out of the institutions, that is a nice step down placement, and you can see the rate is significantly different or lower than the mental health institutes. And we do have a couple of contracts with private inpatient hospitals, and we don't have them with all the hospitals in the region. Just the 3 that are listed this calendar year. And for individuals without health insurance, if a patient would go there under an emergency detention, we would be responsible for those funds.
So who makes a determination of which service an individual ends up needing?
So there is the emergency detention or Chapter 51 process that is determined by either county or we have a contract with Northwest Connections, county mental health staff or contracted mental health staff. And then after that process, if it continues through the court, there's physicians that testify and determine level of care or continued need for placement.
So a couple steps.
Yeah. So yeah, just a little bigger chart of the Fund 54 or community type placements. So those are those adult family homes or community residential facilities that are used for step down placements or for placements for individuals in need of services in the community, the psychosocial rehabilitation supports. So just talking about the community-based residential facilities, there's a cost range. The cost range, like I said, this is a little older presentation. It can vary between $80 a day to up to $2,000 a day. Individuals in those placements are in the support services or the Medicaid reimbursable services to cover most of the costs of those placements. Again, it's a step down before people move back to the community, or sometimes just to maintain people's safety in the community versus a hospital. Then again, adult family homes similarly between $80 and $2,000 a day at our highest end.
So this is moving on to the child institutional type. So again, this is just the graph that goes along. So Jamie, if you want to go to the next slide, which explains it. So mental health institutes, this is again Winnebago. So this is actually, this section of it is determined under the Chapter 51 program. So it is under behavioral health, although it does come out of the child funding because it is allocated in relation to children's placements. So these would be the children that would be hospitalized under those circumstances under emergency detention or long-term mental health treatment needs. Then we go on to the children's residential care centers. So those would be examples of those are like Toledo, Northwest Passage. Those are the 2 that we have most commonly used. Again, those are 267 to about 517 per day. Those ranges do go up each year as their daily rates are set by the state and federal government. So reasons for placement in those facilities would be long-term treatment care needs, often to ensure safety of the individual or the community. Reimbursement resources that we can kind of sometimes get are some private pay, including like the child support, and we can also recoup the child social security that's allocated to them. Secure and non-secure detention stays, we generally use La Crosse County detention, but we have used other facilities across the state. Those range from $130 a day to $190 a day. Again, those are state rates that are set on a yearly basis, so they do increase on a general basis of yearly. So this would be for youth who have committed a delinquent act or what would be considered a criminal act as an adult. And they are a threat to the community and cannot be maintained in the community. Primarily, the secure non-detention stays are only accepting youth who have been in other placements that have been least restrictive, where they continue to offend or be a safety threat, or if they are committing a felony act as a youth.
So you say the rates are set by the state for these different. So it's not like you can, not to this just dollars, we can't really shop. It sounds like all these places have the same rates. It's just more a matter of proximity.
Yes, a matter of proximity and matter of, so like the residential care centers sometimes special in certain types of needs.
Okay.
So Cholita is, would be an example that they deal with children with autism. So there's very limited resources for autism services. So that would be one we use for an autistic youth, where Northwest Passage sometimes we utilize them for like a 30-day assessment for a youth, but we've also utilized them for a longer term treatment stay as well. So some of the facilities specialize to different types of treatment. So that's why there's still a cost range, because it depends on what population they serve and whether they have any specialty services that they provide.
Okay.
So these are the community type placements. So again, that would be our group home, treatment foster care, and regular foster care. We do break those out a little bit, but you can go to the next and we can explain those a little bit more. So youth group homes, we've used Family and Children's Center in La Crosse. We also actually have a group home here in outside of town that we utilize frequently. These are primarily our youth justice population. However, sometimes they have been child in need of protection and services. These rates, again, are set by the state, so they range from about $170 to $253 per day. The reason for using a group home would be that they have 24/7 staff. So in order to keep children in the community who, again, primarily for youth justice purposes would be a threat in their home environment, this would be providing them 24/7 support staff. All of these reimbursements, we can sometimes recoup costs from the parents, child support, and social security, as well as disability of the child. So treatment foster care would be our next step down. We frequently contract with Family Works, Children's Hospital Wisconsin, and Community Care Resources. The cost range per day for those is $74 to $140 per day. Those range a little bit more, and with foster care and treatment foster care, they are based on the child's needs. So there is some fluctuation in those rates based on the child's specific needs. Reasons for placement in those environments in both treatment foster care and regular foster care, the child's needs exceed that of a relative care provider. Treatment foster care would be a higher level where they would be meeting the needs of the kids. They might have more trainings and a higher level of supervision or more restrictive measures in their home. Could be a child with significant mental health or physical health needs, or dietary needs, medical needs that would be needed, but they're not in need of a group home or a hospital setting. Regular foster care would be our entry-level foster home. So these would be primarily our children who are placed in out-of-home care due to neglect, physical or sexual abuse, and can't be kept in a family setting or don't have family members around that can support them in that setting. Some things that we do provide in reducing the stay or the cost to the county is kind of our crisis services, our safety and intervention services, our engagement service, and linking people to those community services similar to behavioral health. We are trying to do a lot of outreach to at-risk families to prevent, and also doing a lot of safety planning to try to reintroduce children into their home settings or community settings and step-down placements. So stabilization and reintegration, so short-term placements to stabilize conditions or situations so that people can safely return to the community. Establishing permanency for children who are in placement. So pursuing adoption or guardianship. The adoption does require a termination of parental rights process, which is a legal process. Guardianship is also a legal process, which is a little bit less invasive than a termination of parental rights, and primarily in relation to guardianships or primarily in relation to children who are placed with relatives. So we do have a 15 out of 22 month timeline under which we try to get permanency for children who are placed out of home, whether that be in reunification, guardianship, or adoption. Enrolling individuals in services that can fund placements. So some of our, with child and youth services, the foster care and treatment foster care, we can enroll them in services such as children's long-term support waiver if they qualify for that service, which can help offset the cost of some of the services and placement costs in those environments. Because those services like speech and different interventions are provided in those higher level group homes and residential care centers, those youth are not eligible in those placement settings for those additional supports and services. Again, we enroll anyone in Medicaid, CCS, family care, any of those types of placements that are eligible through our behavioral health or other intervention services that we provide here to offset both child and youth services as well as adult placements whenever possible.
When you speak of children, are you speaking of anyone under the age of majority, under 18?
Correct. Some children are also eligible over the age of 18 if they have an IEP at school, so special needs, they can be eligible up to age 21 as well for continued placement and services under youth programming.
And during the past years, is there a particular range of age that you normally deal with, like, you know, maybe 8 till 14, or is there any particular, or it varies?
It varies from year to year, and our involvement with families, it varies from month to month even. You know, it really just depends on the clients and what's going on in the community at that point in time.
And with the parents that do the fostering, has it ever been the case where they would adopt the child that they fostered?
Yes, we've had some, we've had family members who have preferred to go through the adoption route versus the guardianship route, as well as just regular foster homes who are conversion homes and are willing to do that. We generally at 6 months of a child being in out-of-home care start speaking with the foster parents, especially if we're not seeing movement by those parents, by the biological parents to work towards reunification, in talking about permanency, because we want a child to remain in a permanent placement if at all possible. And if at 6 months that family's identifying, no, we wouldn't be open to adoption or guardianship, it gives us time to start looking at, is there a transition we need to find in order to locate someone who might be more of a permanent option for this child if the biological family isn't willing to be that, or can't be that option.
Thank you.
What kind of numbers? Give me numbers.
As
How
to,
many kids are?
I think right now we have 11 children in foster care and 7 in treatment foster care, 1 in a residential setting and 1 in a group home setting, if I'm recalling correctly from last month's report.
Less than 25?
Yeah.
And that, a rolling average, that would be our kind of our.
That's been the average, I think, all year. We've had the same amount of placements at the beginning of the year. We're trying to work towards some permanency now with a few families.
And I should have asked that about adult placements too.
Yes,
Yeah.
I'm trying to count.
Yeah,
I know.
We have 7.
Say under 10.
yeah.
I know the little graphs, each color, I think, in that graph represents a client.
Correct.
Okay.
And I can address this, some of the challenges to be addressed. Number 1 is staff turnover. You know, especially, I guess in both units, but with the children's unit, they start working the case plan with the family. They're doing permanency plans with the judge every 6 months. If you have a staff that leaves, you get a new person assigned, it's reestablishing those relationships, re-looking at things, and so that continues children in placement longer than what's expected. You know, same with the mental health unit. If it's different people working with them, they have to start all over, they're getting different supports in place, it does make it difficult. And so those are things that increase the number of placements or increase the time in placements. The limited management support. And so with the two sitting right next to me, both of them are short-staffed. And so different things that they could do to help support their staff, they're unable to do because they're doing case management duties. And so, really the hope is once we get to be full staffed, I can't promise that we're gonna have less placements because sometimes it's just human nature and it's people and we can't control that. But these are things that can provide extra support to the workers and really spend more time focusing on these placements and what do we do to get them back into the community. The limited attorney and social work time. So to file a termination of parental rights, it needs to be done by the corporation counsel. If they're busy and they're unable to get them filed, that delays things. Once the termination is completed, the state takes over. But while it's in the works, that still continues to be the responsibility of the department. And then wait lists. So sometimes there are lesser restrictive and cheaper services that are placements that are available, but they're full and there's not those options. So sometimes we have to have them in a higher expense place only because there's no other place that's available to them.
And the staffing is short because,
Well, I've only been here 3 weeks, so it's hard to say, but I do think one big part of that is the wages. I've been taking a look at some comparables. I've worked at a neighboring county. When you're having a social worker start here at, I think it's $22 an hour, and neighboring counties, they're starting anywhere from 24 to 28. It makes it difficult, when it's really close by for people to go elsewhere. I do think that that's a big piece of it. If it's more, I don't know that at this moment, but that's what I see.
that's thank you for that. You're not an outsider, but you have the advantage of having been elsewhere, so.
With the children's placements, and I'll go real fast because we're off schedule already, they are reviewed every 6 months. So the judge is looking at those placements, is reviewing them, is making sure the department's doing what they need to do, and encouraging workers to get the ball rolling to find that permanence. With the mental health and the children's placements, they're being reviewed on a monthly basis. Who's in placement, how much is it costing us? Can we make referrals to the EDRC to try to get a different funding source in place? And so these are the top of our radar here, placements are, because they are a huge draw on the levy and we are looking at them and really trying to do what we can to bring these costs down. Any other questions real quick on placements?
I have a couple of questions. This is Sean.
Yeah.
So one thing, this is just a little wording issue. Oftentimes at the county board level, these are called institutional placements or institutional placement fund. But a lot of these aren't institutions, like a foster home's not institutional. Why is it called that?
I don't know if it's just always been that way.
Yeah, I guess I'll speak unless someone else wants to speak. I'll give my best assessment of it, I guess. I think historically, looking like way back at board minutes, and just being here for a while, historically institutional placements were many years ago separated out, and it was truly just the Winnebago and Mendota class. And I think another board member asked the question of, did the state fund those things? They did. Historically, the state fully funded those things, and then they have moved to different community resources being funded. But historically, the adult family homes and children's placements stayed within the human services budget, and at somewhere along the way, all placements got moved to those institutional budgets or costs. I can guess what year. I don't know. Angie, you recall what year?
It was largely, I think, labeled by the auditors. Fund 54 and Fund 44, they just titled them that way. Institutional Placement Fund for dash children, dash adults.
Do you think like 2013 or 14?
It's been a while.
It's
Yeah.
been a few years back, yeah.
Yeah, it's quite a few years back.
Okay, well, it's always been a little confusing to me because, you know, I'm assuming some of you in the room know that my spouse and I were foster parents, and so I've ever since I've gotten on the board, I've been wondering, were we an institution? And it didn't seem like it in the presentation you just gave, and so maybe we just need to rename that because it's kind of a little misleading, I think, in the way it's named right now. And then the other thing, I'm not sure if it's a question or just kind of a comment, but it just seems like from what I hear from folks out in the community when they talk about HHS, you know, they are concerned about the placement costs and how those have gone up so much. And I think probably some of the more positive or best people in our community, they really wonder how they can help or what the community can do to drive some of these costs down. And I don't really hear, you know, just sitting on the county board, what I usually hear about is we need more money, the costs are up again. But I don't really hear about, and I'm not saying it's your all's fault necessarily, I think we just need to partner together somehow to kind of change the messaging. I don't hear, this is what we can do to work together to reduce the costs. I always hear, well, you can give us this money, but it might not help, you know? And so it's just, it'd be nice if we could somehow shift the conversation to like a more proactive problem solving approach rather than a kind of doom and gloom approach, which I feel like we always are subjected to.
I think, Sean, when each of the managers start to talk about services they provide in the units, I think you'll start to see what things they're doing to be proactive, to try to stay away from these placements. So, you know, they can talk about them because there are a lot of great things that are happening that are preventing additional placements and preventing other heartbreaks, especially with the mental health, with the children's unit. And as far as community engagement, I think one of the things in talking with Jessica is we don't have any foster homes at this point in time. But again, this goes to the staffing issue. And so when you're looking at prioritizing things, trying to find foster homes is not a priority when you're looking at children's safety and community safety when you look at the youth justice piece of it. And so the hope is once we are able to be full staffed, we can assign somebody to be that foster care coordinator to really go out and do that outreach. Because as you saw from the chart, foster care placements are a lot cheaper than treatment foster care and the group home placement. So those are different things that we can do in the future if we have the staff. But each of the units will talk about some of the things that they do and the services that are provided that every day save money and avoid additional placements.
Yeah, that, and I appreciate that. I just think even when we did have staffing, I don't, you know, we reached out to become foster parents to the county, but I don't ever remember, and maybe I missed this, maybe I wasn't as involved, that we just moved here 8 years ago, but I don't remember seeing that proactive, like, you know, here's how you can help in your community. You can become a foster parent. And actually tying it to this budget issue, because a lot of the people in our community, they are pretty aware of this budget issue, but there's a feeling like there's not a solution, is the sense that I get. So that's why I'm bringing it up. I think if we can partner somehow to improve that communication with the community, I think it could potentially be a help to getting some of these placement costs reduced.
Hey, Sean, Steve Carroll here. Before the meeting, I hadn't heard this until then, but apparently when they had their public presentation, their annual, nobody showed up. So I guess what I'm saying, I'm not sure what the answer is, but it's kind of both, many parties have to step up, I guess what I'm saying. Where's the mic? How can you hear us?
I don't know, but I can hear you really well, so don't worry. Thanks. And I agree, Steve. I think it's got to be a partnership, but sometimes we can't just sit in rooms and expect people to come to us. Maybe when we cut everything, they will, but otherwise, we have to be proactive in our outreach to the community too, is my view on it.
Okay.
All right, so next we have administration and building operation unit with Angie, and then the business and financial service unit with Stephanie.
Okay, administrative services. So this is a merger presentation of both my unit and Steph's unit. I just wanted to let you guys know, I put your org charts out there for you. Each page represents an actual unit. So as you flip through those, it should make sense as the managers come up, who's under which org chart page. You can go ahead and flip. Yep, I went too far. Oh. Back. And again. So this is just our overall mission statement. Every unit of the department has one. So we just put this on there for your knowledge of what our mission statement is. Basically, we support everybody that you're going to hear from this point forward, all of the different units. And you can go ahead and flip. With all these are our areas of responsibility. So every single unit we do something with, like I said, and it's largely under these two lines, columns. Some new things we've added the last year or so, unfortunately with COVID, is social media. We've had to have a Facebook presence, and we've been doing that. We manage that, as well as a lot of the public information that was all pretty much new with COVID. So now we're doing that kind of task work as well. So flip the next one. So this is my unit. You can see it a little closer. Yep, hit the very second page. Yep, there you go. So everyone in yellow in these org charts are a member of management. Green is full-time and purple is part-time. All the big rows at that top with all of the blue coloring, that's each of the programs or units that you'll be seeing here today. So administration at the main front desk, we did kind of a running total on how many calls we answer roughly per year. It's on average about 8,000. We've assisted more than 5,000 walking people. Yes, I had them do tally marks for a while just to see what we had, because we don't have any other way to gauge that. We also have, since September of 2021, an ongoing helped register 900 COVID vaccinations here in this building. When we were offsite, we were doing roughly 200 to 225 vaccines a day that we were running through our offsite clinics. We created and monitored over 100 contracts totaling $6 million. So that's something that almost every single unit touches, our contracting process. We recruit, interview, and have filled 49 vacant positions in the last year. This last year, we processed payroll for 84 county staff. We take minutes at all of the different meetings, support different meetings, not just the board meetings, but also different little committees. So we have about 113 meetings that we did that for. 205 releases of information for clients. So information has to go out from the records. That was processed by our unit, as well as scanning over 24,000 documents into those electronic medical record systems, as you know, you hear of all the time. New is that last bullet, public health pandemic response. We supported all the testing sites, the vaccine clinics, and then also public information. I'm roughly a little over 350 press releases in these last 2 years, largely because of COVID. We'll go to Steph, and just like that.
My turn.
So as fast as we can.
We're
going
going
as fast as we can.
I'll just take my time. Right, so in the business and financial services unit, part of the administration, there's the four of us. I'm the manager, been in this position for a year. Prior to that, though, I was in economic support. I've been a county employee since December of 2011. So familiar with the agency, but in this position for a year. Also in the unit is Deb Dittmer, Kathy Dobbs, and Nikki Chicklett, their fiscal specialists. Each Kathy Dobbs has been here since 1994. So if she leaves us, we're going to have to figure something out there. But the other two gals have been in their position for about a year. You can just stay there, Jamie. So the financial services unit, business and financial services unit, some of the highlights of things that we've done since the last time that this orientation happened. They have submitted over 279,000 CCS claims. That's one of our community-based programs, and we're able to get Medicaid reimbursement. And so we collected $5.3 million just through CCS. We submitted then for the behavioral health, mental health, AODA crisis, and public health claims, including flu shots. We did billing and were able to collect over $430,000 in revenue. We processed nearly 4,500 checks to pay vendors, pay our bills, the light bill, keep the lights on. We also have sent individuals to collection, and we're able to collect over $35,000 from 284 delinquent accounts. And then for individual federal and state programmatic allocations, we claimed $7.1 million to grant to help cover our costs. And just in general, the unit created and monitored a $9.8 million budget. So next page. Yes.
Maybe it's too soon, but my question is, my impression is that your unit needs to be the experts in understanding the jungle of regulations and legislation and optimizing how we get the most money possible to minimize self-funding by the county. So how do you keep up with all of it?
How do I keep up with all of
No,
that?
seriously, is there some
Yeah,
kind of
no, great
information
question.
service or-
Great question. Just really kind of keeping an eye on, when they start talking about the governor's biennial budget, really keeping an eye on, those conversations that are being had, just so we can kind of keep an eye on what's coming down. I'm connected to several distribution lists where they send out, okay, these are the allocations that we're looking at. for
That's what I was
next year.
wondering. So there's some kind of specialized news feeds that you.
Yep, news feeds,
Do your monthly meetings.
monthly, we have financial manager meetings, we have billing specialist meetings, so we're always trying to stay on top of what's going on as far as billing, making sure we're staying current on coding and all those kinds of things. And working with each individual manager, because as you can see, each unit within Health and Human Services has its own little sort of mini
Right.
budget, right? So
Yeah.
all the managers, we talk, they keep me in the loop, we kind of watch from month to month. We go over what they're spending, and later on, I'll kind of point out a place where we try and maximize those dollars, make sure we're bringing in as much revenue as possible. If I see something come in that says, hey, these grants are out there, even the managers, they keep their eyes out for grants. Are there any grants that we can apply for, and those kinds of things. So each unit has its own little mini budget. And then, so they each have their own little mini budget. So administration, that's Angie and I, that's our unit, that's Trisha, that's that whole gang that sort of keeps this building up and running, and does the support for the other units. And then public health and nutrition, public health, right? They're the ones that are running COVID, so they have their own budget. We have the nutrition program, the Aging and Disability Research Center with all their aging programs, economic support, child abuse services. You just heard from Jessica on their budget and their funding, or their budget, and the behavioral health is the biggest pot, but then that can be broken out into all these individual expenses. And then I did add the adult and children's placements there at the bottom, and that was what our 2022 budget amount came to. That's our budget, and then it's all broken out into all of these different revenue sources, non-levy, levy. Did you raise your hand? No? Okay. And then oh, geez. Yeah, so I did a quick cell check, and there's over 100 revenue funding streams that come in, so like 103 or something. Yeah, so
Could I
yes.
ask a question and make a comment? One of the things, as we're involved in doing the budget, we're getting a lot of public input, and one of the emails that I got was from a gentleman who said, several directors ago, we must have had a maestro in charge of getting grant funding. And the assertion was, well, since that gentleman left, we no longer get grants. So I doubt that's true. And I guess I doubt that's true. And I'm reassured by what you just told me that, you know, we have a constant monitoring of grant availability.
Right.
So I doubt that we are no longer getting grants. So,
Yeah, and the thing about grants is grants are very program specific, right? So if you get a grant for a later, like in behavioral health, right, you have AOTA. We have substance abuse treatment, things like that, treatment for it. It's very specific on what we can spend the money on, but at least it's something that supports, that helps the community and, you know.
and one of the things about grant that I hear is, well, you get the grant and you establish the program, and then the grant runs out, and then you're stuck holding the bag.
Yeah, so, but then that's the goal is to then find another grant to kind of backfill that.
I think one of the big ones was public health. For many years, public health did a lot of health education, awareness. They did a lot of those farm to school, whatever it was, kind of stuff for a while there. I think we had like 5 or 6 different grants at that time. They all dried up. They went about 5 years and then they dried up.
But really, in general, this budget is just our plan for the year, right? It's what we expect our expenses to be, where do we expect to get our revenues from? And then sometimes at the end of the year, you've probably heard that Health and Human Services has some money left over, so that's always a nice thing. We're able to give back to cover overages in the placement fund at that point, and then we're also, if there's still anything left, then we give it back to the general fund.
But that was primarily due to the pandemic, wasn't it?
Yes and no, I think some of them are, but some of them is additional funds from WIMCR, which is a reporting system through the mental health and other programs. So part of it is, I know with like economic support, additional funds were received because of the Medicaid reimbursement. Sometimes that's determined after the fact. I know right now there's a meeting coming up, I think it's later this week, for the Children and Youth Services about additional funds that are going to be coming. We had no idea about them. They're going to be coming this year. And so those are things that we don't put into the budget. We don't expect to get, but they're added bonuses when we get them.
The next one. And so this is just a different visual kind of the
Oh,
makeup.
do you mind if I say one thing before you move on? Thanks for putting that together. It's really clear and easy to read, that previous slide. So I just wanted to say that. And then I'm assuming that I see that the division of HHS that has the most cost besides the placements is administration. I don't know if you can go back to that slide. But I see that you all bring in quite a bit of non-property tax levy. I'm assuming that we're billing for a lot. Are we billing our overhead, and are we billing as much overhead as we can?
Yes, absolutely. So I think, and it's later in another revenue slide, but I can touch on it now. Yes, so even though, so a lot of our programmatic funding, and I'll give economic support as an example, we can claim what's called AMSO. It's administrative management overhead. Anyway, don't ask me the acronym, but yeah, we can claim administrative and overhead dollars and get reimbursed for those. So yeah, a lot of that funding goes into that, and that's what's able to be non-levy revenue and keep that. We get, so economic support, I know we get money from the ADRC, we also get funding from, and then we're able to, especially through WIMCR, our Medicaid reconciliation, we get quite a bit of funding back in that situation too. So yeah. Glad that you noticed that. Yeah.
Great, thank you.
Yeah, one thing I did want to point out, building and I do have it later, but building and operating costs, you can see $382,915 is in our budget. And what's interesting about that is we're responsible for all the costs of this building, from everything from the lights to if to everything. So that's something that's a little bit unique for Health and Human Services. We have all those costs that are internal to us, but like I said, we do get reimbursed for a large chunk of that, so.
Are we also billing for the new roof that's on the debt levy? It's not on the operating side. Can we bill that as overhead?
That one I think was taken out of,
Special account, yeah,
that
special
was
money.
that, the capital improvements. I think the roof came out of that. Yeah, so if we were able to do let's say for some reason that roof did not come out of the capital improvement loan or whatever, then yes, we could have charged that through overhead and gotten reimbursed for some of it. Not all of it, but some of it. Not all of it though.
So you're saying that if we had just put that on the operating side, we could, but because it's on the debt levy side, we can't charge overhead?
We didn't even really pay it.
Yeah, we didn't pay that at all.
HHS didn't pay it.
That might be one thing to explore. Is there a possibility for recouping some of that
Well-
cost as well?
Well, so we still have allocation limits though too, right? So it's not like we would ever get 100% reimbursed for that.
No, but even if, I don't remember what the cost was, I'd have to look back at our records, but if it's 200 grand, for the roof and we could get 20% of that back, well, that's 40 grand, so.
Right, but the difference would still have to come out of the capital improvement, so I think that's why it just got all built into that. I don't know,
But it might be another way to,
Struggling with the roof, trying to include it in operational expense about 4 years ago.
yeah,
And I told her, take it out, handle it as a separate line. Then we brought it up through the capital expenditures. There's gotta be a bookkeeping procedure done, Sean, beyond this group's knowledge. I would hope that gives us depreciation expense on the roof. It's gotta be. It's gotta be there somewhere. I don't know where it is, so can't tell you.
yeah, I'm just saying it might be something worth exploring, or maybe in the future, we don't want to put anything from borrowed money toward the HHS building. Maybe we'd rather swap some money from elsewhere and put you all on the operating side to do a capital project so that we can recoup some of those costs. So that's why I'm saying maybe we could save some money if we just did some thinking about how to get more money out of the state and feds or whoever is paying for those things. Because if we can't get it, if someone else is paying for it, as you all look at it, it's the clerk's office, the administrator's office, they're paying for it. Why not put it on your side, but then figure out how to get you all additional revenue to cover that, and then get some of the money from the state and the feds to pay for that roof.
and I think that's what Marty was alluding to, is we tried to do that previously to get the additional tax levy in our budget to do that, but we had to pull
Well,
it
we
out.
didn't have
so,
any tax levy to give them,
yeah,
so.
Because then, yeah, you're right, we could see what we could get, we could try, but.
Question. We rent this space, don't we?
Own it.
Oh, I thought we rented this. I didn't realize
It's a
we owned
county
it.
owned building,
Okay.
the HHS.
It's one of our many buildings that we own.
I was under the impression that someone else had leased the space to us.
We own dozens.
Then I have no question.
So if we go back to expenses, well, I'll keep on going here. I know they talked a lot about placements, so this chart just kind of shows you where that chunk of adult placements, that chunk of pie there. I won't go into how much it costs per month and all that kind of stuff. They already talked about that. I know, okay, so, and then revenue. So I know we're just talking about tax levy. So all of those expenses are covered really out of these four main pots of money. We have public charges for services, and that includes sources from revenue such as Medicaid, Medicare reimbursements, all our insurance billing that we do. We talked about the WIPR receiving funding for that. And then state and federal funding, intergovernmental grants, state and federal reimbursements. So yes, we do get those allocations, but I think I already mentioned that it has to be for an expense specific to that program, or like we were just talking about overhead. So what we try really hard to do with those, and I think this was mentioned, you over here brought that up, that that's what we try to do. We kind of try and watch and make sure that we maximize, that we are getting those full dollars, that we're not leaving any money on the table. We're always trying to do that. And then we do get a little bit of money from from sending people to collections, I mentioned before, and we do get money from fines from across the street. And then tax levy, I kind of broke it out into 3 more little pieces there. The placement fund, you can see, it's pulled out there. And then another large portion, that's the largest portion of our tax levy. The remainder of our tax levy, we can break down a little bit further into a portion that's required for some of our programs. We call them matches, maintenance of effort. And so in those instances, it should be noted that even if we reduce staff or cut expenses, we don't save any tax levy. And I think Tricia brought that up earlier. For example, in economic support. So how the budget works is there's $929,000 in the economic support budget. Of that, $153,272 is the maintenance of effort. If we're below that, if we reduce our expenses, we still pay $153,272. If it goes the other way and we go over our allocation, the thing that's nice about economic support, actually with I believe with the ADRC and the CCS as well, is we would get a federal match back on some of that. So while it might tip into some extra tax levy, it doesn't necessarily cost us that full amount. So that's what's kind of nice. So basically the state fully funds programs up to a limit, but then we can capture the reimbursement from the federal government at least. I know in economic support it's at 50%.
Is this slide available any place where I could read it?
I don't know.
I was gonna ask where the whole slide deck is gonna be, so we can.
Yeah, I can try to zip all that.
Oh, do you have a
Yeah,
summary or
yeah,
what is
we
it?
can try to, so they're all individual PowerPoints that we would have to, I think, get IT to zip them all together and put them out to everybody. But absolutely, they're
Yeah, sure.
available. It's just, you want them in 10
Well, this one in
individuals,
particular,
PowerPoints, or
Either
all
way,
try to put it all together, either
Just need
one.
to be able to read it.
Yep.
Yeah.
Good
So really,
time to
I
do
think
that.
that you kind of noticed too, that tax levy and the non-mandated or the non-match MOE tax levy is really only 6% of our total budget. So,
That's pretty important information.
so yeah, so last slide, I think was our last one.
Yeah, so these are our future questions, our concerns, our issues that we're having. We do continue to maximize, like we said, those revenues and improve on our billing and invoicing practices, trying to get in more money. We're trying to expand upon our recruitment and retention efforts that largely falls with administration. Even we're filling jobs for all these positions, all these units. Becoming creative with what we're going to do. So further implementation of that electronic health record system. We want to try to become paperless. It's a little ways down the road, but I think it's something that we can do. We want to make sure admin processes are sustainable with the continued growth of CCS. So what that means is as we continue to grow CCS, as more and more clients come off that wait list, we add more people to actually case manage them, but we got to make sure we add more administrative staff on the back end too, because we're processing all the paperwork, invoices, all that kind of stuff. Building issues, that's probably the hardest thing here is we have 84 offices. You wouldn't know it as you look at the building. It's a big place. I'll be giving a tour later this afternoon after all the presentations, but one of the borrowed money items on the agenda right now is those 18 HVAC aging units. So we have a real problem here. We're living on, the last of them are 20 plus years old. Even the new area was done in 2009. We're already starting to have a few issues with those. The second bullet is something else we've talked about for many years. I think, Marty, even when you were back on HHS board, is changing us to all over to LED light fixtures. We're very outdated. It's hard to find fluorescent bulbs that fill these. Sometimes that's why we just don't have them filled. out. Possible remodeling and utilization of the computer lab area. That's an area where MIS is at, and also the Richland County Coroner. And we have HVAC issues back there. So we're talking about how can we use that space better. And then the last is the possible shed construction for the ADRC. They have some money for transportation vehicles that are just sitting out in the parking lot. They want to look at, they have some money. They'd like to do some shed construction either here or acquire some property, something like that, to be able to cover those vehicles. Those are all building issues that we have. I think 2 of them are on the borrowed money fund. No, 3 are on the borrowed money fund projections over the next few years.
Which, if I can jump in, I just had a thought about that. There was another reason why we were trying to do it as a capital improvement, because there's limits on how much we can increase tax levy.
Yeah.
So if we were, so I think if we were gonna try and do what you were thinking, yeah, but it's not, I mean, it's worth checking into and seeing if that's an option. But that was another piece of it too.
The reason we have 18 aging HVAC systems is because this building was originally a grocery store. One big area with a cooler. And so when you chop it up into little offices, then you have a problem of getting proper air ventilation flow.
And
That's why.
we've added on now 3 different times. And we always have to take the lowest bidder. So not everything matches up with what was in there in the previous that we're trying to hook up. So we run into problems. So yeah, and then we've done some internal remodeling as well. And then we put a wall in the middle of a cubicle area and didn't address the HVAC issues that might create. So now we have serious heating and cooling issues. But depending upon what side of the wall you sit on.
But it's comfortable in there.
Yes.
So, can I ask a question?
You bet.
I see that the administrator's recommendation for capital funding for next year includes $150,000 for the HHS HVAC system to come out of short-term borrowing. So Fund 92. So is $150,000 going to adequately address those issues, and how long would it address those for?
Yeah, that's a great question, Sean. We've actually brought in, this request is about 4 years old, and we brought in a couple different vendors, local, that weren't even interested in bidding out the project because they didn't even know where to start. And it's almost like we need somebody that we need to invest in somebody, an engineer or somebody, to put together a plan that makes the best sense, make us more energy efficient, actually literally go up and look at what's in the drop ceiling and track things back. But, I had mentioned to Tricia, it'd be great if we could, I don't know if Russ Mullins, remember we worked with him on the
That's what we
roofing
need, a Russ
project?
Mullins.
Yes, we
HVAC.
need a Russ Mullins in this. I don't know how much he costs. I have no idea, but somebody that can work with them and get the
Well,
RFP.
Maybe not Russ, but perhaps someone else that
Yes.
is engineering for him.
Yes, put out an
Something we should
RFP,
look into.
ask for bids, and get people that actually want to come here and look at the kind of a little bit of a mess that we have here above these ceilings.
So where did the $150,000 number come from?
I have no idea, honestly. I think maybe it's something Tracy gave him as a rough guess. It may have been is she may have taken roughly $5,000 per heating and cooling unit and multiplied that out. I'm not really sure. We never received a formal estimate on that at all.
I can tell you that'll never come.
No.
Yeah.
And
It might be double.
yeah. And especially if we add somebody like Russ, which I think is very valuable to keep everything moving forward and make sure everything's energy efficient. It's the best plan. You have some people that have a opinion that all the AC units should be put on the roof. I don't know if that's the best idea compared to put outside. Right now we have 18. We have some up in drop ceilings in different parts of this building. They're all over the place. So I don't know that 150,000 is accurate. I know they also put on there, I think 26,000 for that light fixtures. I think that was just to buy the bulbs. 26,000 or whatever. It was not, they didn't talk about what are these things? The actual fixtures themselves, installation, ballast, bulb, everything that goes along with putting lighting in 84 individual offices plus all of the common areas. So, yeah, I don't know where those numbers came from necessarily.
Well, Marty and Steve, I just wonder if maybe we should, in finance, work to refine that number to be a little more accurate and maybe reprogram some funds. It sounds like some design work needs to be done first, and then you have to come up with an estimate during the design. And then of course, after that, then you bid it out and actually get costs. But it seems to me that the 150 is sort of grabbed out of the air, and it's not for 2023. We need a more accurate number so that we're well prepared. Just my 2 cents on it.
So maybe it's budgeting to pay for somebody to do all of that planning,
Research and
and then
planning.
maybe
yeah.
2024 or something.
It's all part of administration, which we don't have yet, which we have to work toward, but yes.
So the strategic.
All right, so now we will go on to our economic support unit. Okay, this is my first year joining this, and I'm sorry, this isn't exactly what you're looking for, but I was just going in what we do from day to day. Stephanie kind of covered our budget situation. So, yeah.
But that's why I don't.
Yeah, so my name is Brianna Turk. I'm the Economic Support Unit Manager. I've been doing this since September 27th of 2021. Before that, I was Economic Support Specialist since January 1st of 2001. So, I will go to our mission statement. And our mission statement is the Richland County Health and Human Services Economic Support Unit believes that all persons applying for assistance have the right to be treated with respect, dignity, and confidentiality. Our mission is to provide families with individuals, geez, I even have my glasses, and individuals who are elderly, blind, or disabled with services needed to achieve economic independence, including referrals to appropriate agencies. So next we have, this is our list of staff.
The screen's getting bigger.
Yeah, isn't that nice?
It's
Now I
magic.
can read it.
There you
Okay.
go. Thank you.
Yeah.
So on our team who are committed to that mission, we've got me and my lead economic support specialist is Darren Steinmetz, and then we've got Barb Otteson, who specializes in childcare program, Lori Brinkley, who specializes in the elderly, blind, and disabled program, and also the long-term care. Tony Cabrera specializes in the energy assistance program, and she's also our walk-in person. So if someone walks into the office, she's the one that they talk to. And then our other folks are Amanda Oman, Amber Morris, Becky Dahlberg, Billy Cordero, Connie Ostrowski, Crystal Adams, Darian Ostrowski, Kelly Mormon, Mark Tracy, and Savannah Tiedrick. And I was surprised to see that our unit has a combined total of 105 years of experience, so I was pretty proud of that. You may be wondering why we have so many. The answer to that is, so back before 2012, when we joined the consortium, every county did their own thing. So every county had their clients or their customers, they dealt with their own county's customers. So Richland County would have only had Richland County residents. The state, in 2012, the state said we need to go into consortiums. So we did, and we joined the Capital Consortium, and there's 8 counties that we're with. So the whole consortium takes on the workload for all the counties. So in 2015, Capital Consortium was given money to hire more people. And the consortium looked at it and said, well, Richland County ESS are paid the least of all the other counties. So it would make more sense or get more bang for a buck, so to speak. In Richland County, we could hire more workers for the amount of money that was given. And that's why the workers were hired here versus in Dade County, where they may only receive a fraction of the workers.
And the consortium paid for all of those workers.
Correct. Yes.
2 questions. Did you say the state said for people to create these regional consortiums?
to be, because it was, the caseloads were getting high enough that we weren't able to keep up. So they consortiums and created a call center.
Okay, so the folks that are actually sitting here could be handling anyone anywhere in the region.
Correct, and right, in those 8 counties,
Okay.
correct, yeah. And it works because the programs are statewide, so all the policy is the same across the state. Okay,
So when you say that those employees are paid, it's no cost to the county, paid by the consortium. Do we get anything for the things we just talked about, the heat, the lights, the office desks, the cubicles, the carpeting,
We get about 16,000 a year per worker that we have.
and I have to apologize, again, I've been doing this less than a year, so the budget, I'm still learning all that. Okay, so you may be wondering what we do here. This is a pretty good video that I found, or that I was showed, and yes, please, and then you'll need to choose a, maybe. Hopefully. Oh, if it doesn't work, I can just tell you what we do too. For the sake of time, let's just.
we can watch the stunning camper van.
Yeah. Be more interesting. That's more interesting than what we do, I'm sure. So what we do is, our folks they spend most of their day on the call center. So they take calls for the whole day except for about an hour and a half. 45 minutes actually for family workers to do work on their caseloads. The rest of the time they're on the phones, they're doing renewals with people. They're doing applications with folks, they're just answering questions. So that is what most of their day is. And then as they do applications, we need verification, so the verification, I'm sorry.
Help me out here. I honestly don't know what these calls are asking for. Is this someone who doesn't know how to navigate all the different programs, they need help, or they've been told to contact?
That would have been, the video would have been
I'm gonna try it.
great.
Community and across Wisconsin, thousands are in need of guidance in program eligibility. Joining the Economic Support Specialist team will allow you the opportunity to have a positive impact within your community. But you may still be wondering exactly what you would be doing if you decide to pursue this rewarding yet challenging career. As an Economic Support Specialist, you will have multiple responsibilities, including processing applications, case maintenance, and determining eligibility for individuals who apply for healthcare coverage, food assistance, or childcare through various programs, such as Badger Care Plus, Medicaid, Food Share, and childcare. One of the main responsibilities as an economic support specialist is working on a call center assisting applicants and members who are applying for benefits, reporting changes to their case, or have general questions about their benefits or other community resources. We operate a full-service call change center, which you would be answering calls in for at least half of your day. Your whole day will be devoted to getting the right benefits to the right people in a timely manner. Economic Support has a unique and extensive training program that you will complete at the beginning of your tenure to help prepare you for a position as an economic support specialist. Let's look at what it's like to be an economic support specialist.
There's a lot that goes into it that's not.
Okay, so that's good. That's what we do.
Okay,
Yeah.
sorry. So I guess my question is, does that mean the economic support specialists are the single portal that people have to go through, or is this more to do with the fact that all the programs are complex and intricate enough, people have a hard time doing it on their own?
We are the single, I mean, we are, like you said, we are
Okay,
the,
all right.
they have to come to us.
Got it.
The
Yes.
starting point.
Correct, yeah, right, whether they apply online, by phone, by mail, we are the ones that have to process.
Okay, so that explains why 27% in Richland County. I mean, are you guys gonna break that down a little bit? But that's, I never realized it was so much. Where it says 27% of Richland County residents have.
Oh. I wish I would have brought that with me.
Yeah, 62.
Page you're on, Steve.
62.
Right, you have so many programs that that's their only way is to go through us, so that's why it's so high.
Okay.
So it's not like we're not someone who assists someone to apply. We are the starting, we
Got it.
are the
Okay.
ones that they apply.
So I'm just curious what the percentage is for the other counties in the consortium.
That's a good question, I'm not sure.
Okay.
Okay, so the programs that we deal with are food share. And then. Okay, so the food share program is also known as SNAP, which is the Supplemental Nutrition Assistance Program. That is what the federal government calls it. It used to be food stamps. Wisconsin changed the name many years ago to food share. And it was, as you see there, it's created to stop hunger, and by the Food Stamp Act of 1964, initiated by Lyndon B. Johnson. And let's see, anyone can apply, but they do have to meet financial and non-financial eligibility.
How often are these cases reviewed?
So what happens is they apply, and then 6 months later, depending on their situation, they have to do what's called a 6-month report form. So they have to fill out this form telling us if they have changes. If they say no changes, then they're good to go for another 6 months. If they say there's changes, like a new job, we would ask for verification.
I'm gonna say, yeah, do we have the manpower to verify these forms that are filled out?
What happens is the forms come in and the workers do process them, and then if we need verification, the verification comes back and the workers process the verification. So that's basically going on good faith, because they send that form and say yes or no, they have changes. And then at 12 months, they have to do a full-on renewal. But in the meantime, we are getting what they call data exchange for wages. So whatever is reported to the state, they do data exchange for us and tell us, hey, you know, that so-and-so has had wages for first quarter. And then that prompts us to go in and check it out. All right, second, we have the child care program. The child care program is also called SHARES, and it helps families with child care costs by subsidizing a portion of their total cost based on their needed hours of care while working or participating in an approved activity. As with food share and all our programs, really, there are financial and non-financial eligibility requirements that must be met. And then also, like food share, the family pays for their care with a debit card. And then we're also responsible for certifying childcare facilities. Okay, next we have the healthcare programs, Badger Care and Medical Assistance. So what they're broken down into are the two different types, Badger Care Plus and Medical Assistance. Both of these fall under the Medicaid umbrella. So Badger Care is for families and individuals without dependent children under 19. Medical assistance is for the elderly, blind, and disabled folks, and this includes the long-term care programs of institutional Medicaid. So that would be someone who's living in a nursing home. Family care and IRIS, and family care and IRIS are programs to keep people in their home. It pays to bring in help so they can stay there. Both of these programs have income and eligibility criteria that must be met in order to be eligible. Medical assistance has the additional eligibility criteria of assets. So we have to verify what they have for assets, which would be life insurance, bank accounts, properties. And that gets very complicated. Next program is caretaker supplements. And this program is a cash benefit that's available to parents who are eligible for SSI or supplemental security income payments. So CTS benefits are, well, caretaker supplement is also called CTS, and the payments are $250 a month for the first eligible child and $150 for each additional child. And children must meet income and asset requirements to be eligible, and the children must not be on SSI themselves. So it's basically to help parents who are on the limited SSI income, helps them take care of their kids. And finally, we have the Energy Assistance Program. And that is a program that's separate from what we deal with the consortium. The Energy Assistance Program is still done county to county. So Tony is our energy assistance guru. She's the one that handled all the applications. So that is, the season for that is October 1st through May 15th of each year. So what they do is folks can apply one time for a year. So they would apply in October, they can apply in any of those months, October to May 15th. And let's see, and then they could be eligible, if they're eligible, they'll get a one-time payment based on their income and then also what their expenses are for heating and electric. And we also provide crisis and proactive services to assist the applicants. So that means if they are in a threat of getting their heat shut off for non-payment of the bill, we can give them crisis funds to assist, to keep that from happening.
You said that Tony was the person that was
Yes.
primary for that?
Yeah.
Thank you.
Let's see. So Southwest Cap, we work with Southwest Cap when it comes to weatherization and the furnace repair and replacement. They're the ones that get the referral. When we do the referral in our system, they're the ones that actually contact their vendors, their people to go out and make the repairs.
So you guys do the means testing and identify, but then it passes on to,
Southwest Cap for them to actually go ahead and do it.
and their funding is, who knows?
Yeah.
Okay.
Yeah, sorry. Yeah, so this thing is, this is just from stats, and this, I pulled it right from the book, so you already have all this information. But Richland County residents received over $6 million in food share benefits in 2021. Childcare for over 45,000 was paid to providers on behalf of Richland County families. Badger care and medical assistance, so that in 2020, over 36 million was paid on behalf of Richland County residents. And 16 children received benefits in 2018 and 17 children in 2021. And energy assistance, 763 Richland County households received assistance with heat and or electric expenses this year. So our goal for next year is to get the word out more for the energy assistance, do more out in the community. I know Tony plans on going to the meal sites to get applications. We want to help as many people as possible with that. Any questions? I'm sorry, I didn't go through how to apply. So the fastest way to apply for folks for the food share, Badger care, medical assistance, CTS and childcare is to go to the access.wisconsin.gov. And then the other ways to apply are there's 4 different ways. There's online, telephone, in person, and by paper. So those are the ways to apply, and they can call the consortium and talk to it could be any person out of those 8 counties. And then for energy assistance, that would be, they could go to the local office here and pick up an application. They could call Tony and request one to be mailed out, and they could also call and set up a face-to-face appointment with Tony to have an interview, and she does the application right there. All right, now, any questions? All right, thank you.
Miranda, you probably.
I have a question.
Oh, go ahead, Sean.
I'm just wondering about, for those who are of working age and capable of working, are there certain requirements that you all either enforce, or do you have a role in encouraging people to work? Is there a limit in benefits? And I know it's probably different for different programs. So I was just wondering if you could speak a little about that.
There is, okay, so the only program that looks at that is food share. And if this were normal times and not COVID times, they would have a maximum of 3 months golly, it's been so long. Here in a couple of years, I believe, that they could get benefits, but they have to meet an exemption or become not what they call an ABOD, which is an able-bodied adult without dependents. So if someone is not able to work because of a physical or mental disability, they can get that form filled out by their doctor, and then they can continue to receive benefits without having to go to work. But yes, there definitely is, they encourage that, and there's also the FSET program, which is the Food Share Employment and Training Program, and we refer people to that who don't meet an exemption.
Thanks.
Okay.
I have one more. Are there any is there anything built in the system that, so I understand at a certain point in your life, everybody has a need. When I was a kid, my dad had an accident, we had a need. Is there a way of weaning them off? So say they get a job, but it doesn't quite cover the difference. They're not making enough, but it's enough to bring this down a little bit as their employment goes up. Is there a way that we can do these transitions?
Unfortunately, there's no slow.
I've heard other people talk about that. I'm like, well, that makes sense. I mean,
The sliding
And
scale.
it would
Yeah.
make sense for it to be a gradual, but it actually, if you got it.
instead of right now, if they get a job, they lose it. So that's incentive for some people to not get a job.
You're right. You're right.
And some of it is income based, so if your income goes up, you might go bounce off of like Badger Care, your food share goes down if your income goes up.
Right, so it's not if you get a job period, you're off,
Right.
it's what your income is.
Okay, so there is
There
a
is,
slide scale, like
yeah.
you said, or.
In a way, yes,
Yeah.
and, yeah, but if you get a job and your income is immediately over the limit, you're off. Alright.
Miranda.
So behavioral health is our largest unit, I believe, in the agency. So I'll just spend a few minutes and go through each area that we serve or cover. So just a quick overview of each program area I'm going to go through. So we have outpatient mental health treatment services, substance abuse treatment services, crisis services, our comprehensive community services and coordinated services teams, intoxicated driver assessment services, treatment court program services, adult protective services, and birth to free and children's long-term support services. And I'll go through the slides and feel free to ask questions either as I'm going through them or at the end. So our outpatient clinic services covers a few areas. We offer mental health counseling and psychotherapy, substance abuse treatment counseling, psychological assessments and services, And we have our psychiatric evaluation and medication management programming. And these areas cover assistance with a wide range of issues ranging from depression and anxiety, childhood emotional issues, abuse issues, domestic violence, stress, and coping with major mental illness. Payment for these services includes Medicaid, Medicare, private insurance, and private pay to cover these services. And then under DHS money, because we're a county human services agency, individuals with no insurance are eligible for a sliding fee scale based on their income. So as you can see, our outpatient clinic services, our numbers have dropped since 2017. We have had different staff turnover, things happen certainly since then. And on average, we're serving about 100 patients a year, 100 individuals.
So all of the assessments and clinical stuff is done just by 2 people? Or do you subcontract that a lot?
Not for these programs. This is our current clinical staff. Last year, we did have 3 clinicians in that program. But right now, we do have 2 staff.
Okay.
So I'll speak to Allison. The first one listed serves patients primarily in our building. And then we have an MOU or an agreement with the Richland School District. So the second therapist listed does therapy at clinics in the within the Richland schools. She is able to do therapy with parental permission. And then also as part of our outpatient clinic services, again, this has been a change just in the last few months with staff turnover, but presently we have 2 staff that provide outpatient substance abuse treatment. And our numbers, except for 2017 when we didn't have a primary provider in that clinic, stay at about 100 patients a year for the outpatient substance abuse treatment. So related to our outpatient substance abuse treatment services, Richland County does have a sobriety court. A sobriety court is an evidence-based treatment model to work with individuals who are considered high risk. This program in Richland County serves residents who have 3 or more OWI convictions and suffer from alcohol dependence issues. The court on just this calendar year integrated individuals with drug convictions as well. There's criteria for individuals that they have to meet to be served as part of the treatment court with those drug convictions. This program has multiple staff from ranging from probation and parole to law enforcement to outpatient treatment providers, both within this agency and within the community to provide wraparound treatment services. This program is funded through a treatment alternative and diversion grant through the Wisconsin Department of Justice, along with tax levy. And Tiffany Olson is our treatment court coordinator. I just one more mention about treatment court. The treatment court diversions typically include decreased sentencing time for individuals in that program, decreased either prison or jail time spent for those who successfully complete programming. Also, as part of our outpatient clinic services, we have psychological evaluation services with Dr. Jean Warrior. Dr. Warrior assists with doing diagnostic testing and treatment recommendations. Most commonly, we'll work with Dr. Warrior for individuals coming in, often through our Aging and Disability Resource Center, or individuals turning 18 that may have diagnostic needs to get a guardian and get adult services and benefits. And then we have our outpatient psychiatric clinic. Psychiatric evaluations and medication management services are provided to those who benefit from medication management in order to treat their psychological substance use treatment needs. Care is provided via telehealth, so we had telehealth in our clinic before the pandemic, but it's certainly proved beneficial throughout the pandemic. Without our psychiatric provider, or rather with our psychiatric provider, we're able to serve patients who would otherwise often be in a hospital setting to get their medication needs met. And we contract with an agency in order to have our psychiatric provider. It's proved very hard to find a person to come to Richland County or a rural area in person. So we contract and work with Dr. Marianne Tetsioson, and then we have 2 nurses. One is full-time, but not full-time with the clinic. Anyway, they're both part-time in their clinic setting that work.
What is the county's plan or process for if during this treatment or evaluation of psychological issues, if they feel that someone has possibly become to the point of harming others, what is the reporting process? Just a brief synopsis of what happens there.
Yeah, just real briefly, we would use our crisis services assessment process, which includes crisis services assessment by county staff. And then we always, law enforcement is part of that process under the law, but also, yeah, if someone would be dangerous to others, we have to include that as part of that process. Yeah, that leads right into the crisis services. We are, each of these areas, we hold a DHS state certification in order to be able to bill services and also to have oversight. So it's DHS 34 that mandates or that oversees our crisis services. Daytime crisis services are provided by behavioral health or clinical services staff. After hours, we have a contract with Northwest Connections. Northwest Connections does 24 hours a day answer the phone service. However, our daytime staff cover walk-in crisis assessments and any in-person crisis that occur during the day. We're also mandated to follow up with each crisis assessment that comes through that telephone line to be sure individuals get the services that they are needing. And those services are billable to Medicaid and private insurance. The county has a small MOE that they have to pay in order to get the 100% Medicaid reimbursement through crisis services. So you can see, it just have listed our crisis staff, everyone in most of the unit, most of the behavioral health unit serves and covers crisis for linkage and follow-up. You can see our crisis numbers of notes in 2020. You can see the years and part of 2019. We were able to have the full-time crisis staff position filled. We do believe in those years there were actually more, we know there were more individuals served, but also the crisis worker was able to do more linkage and follow-up with those patients. We have higher insurance reimbursements during those years.
Okay, so those 9 or so folks, where do they sit? Are they all have different functions then, or?
They're all, so there's different levels of training. They're all trained to do crisis linkage and follow-up. The master's level staff do supervision. We do have a doctor that comes in every 2 weeks that is available for supervision and consultation. And yes, they all are in a rotation or scheduled to do crisis linkage and follow-up.
Crisis.
Okay, and they're all housed in this building.
Okay.
Yes.
They can use the 988 number 2, the new 988.
Yeah, I don't have a slide in here, but yeah, that's brand new this week. And that actually links, can link to Northwest Connections, our call center, if they get someone from our region.
Who answers that? Is it-
There's a,
Suicide,
it's a state call, actually, I
So
think,
it goes essentially to Madison?
that's a nationwide,
yeah, it's a
Do they break
it's
that?
like 911, if you're suicidal, something, you just dial 988, and then it connects you to
That's why we're
Somebody
dialing
Wisconsin or
10
whatever.
digits on our phones now.
and they will get you back to local,
Yeah.
local health if you need that.
Where would the call center be?
I don't think
This
our
is new.
dispatchers have left there, so.
It is there, I believe, from my state meetings, there's multiple call centers throughout.
When I first heard about the 988, I was wondering if we'll go to the sheriff's department,
No,
kind of go out from there, or what the hierarchy of this whole business is.
Assume it's just nationwide, and then they'll ask you where you're at, and it'll go to that local call center.
Yeah, but then who do they call?
My guess is they have like a mental health therapist on
Right.
staff.
Like one of these
yeah,
people.
Yeah. So like if somebody from Richland called that, they'd say I'm a Richland County resident, then they'd send it to Northwest.
right, they will get them to our call center, Northwest
center.
Connections, and Northwest does have like a direct call, able to call law enforcement if they're needing to, so.
It's better, because as like veteran suicide, I used to carry around a 800 number in my wallet in case that's somebody I knew, but
You know,
this 988 is a lot better.
yeah, because
I can remember that.
Yes.
I remember.
Do you all,
Dial 1 to make a long distance call, so. It's a minor bother, I know, but.
Sean, did you have a question?
yeah, I was just gonna ask if you all partner with the sheriff's department, say they're out on a call, and there's a confrontation with someone who's who appears to them to have a mental illness. I'm just wondering about if or how you all intersect with the sheriff's department with a call like that.
We do partner with the sheriff's departments and police departments. It depends on the situation. They will call us or Northwest Connections. Both, we've gone out with law enforcement, they've asked us to meet them there. They'll bring individuals into our office to be seen. And sometimes they will work through the phone line too and call Northwest Connections.
So sometimes, did I hear that right? Sometimes you all physically go with a deputy to a call if you're called out by them?
Yes, we do.
Okay, thank you.
Just a little bit about hospital diversions. Hospital diversion is possible with a safety plan if someone is in crisis at times. There's a risk assessment conducted if diversion with safety planning is appropriate. Obviously, going to the hospital is not always preferred for most people. So if we can work with someone to get outpatient services or see the psychiatrist here, and they have a way to be safe in their home, that's always less traumatic and less disruptive. And a little bit about our birth to free services. Birth to free is an early intervention programming for children between the ages of 0 and 3 that reside in the county. To be eligible for birth to free programming, a child needs to show a 25% delay in one or more of the key areas of development: social, emotional, physical, cognitive, adaptive, and/or communication. They have to have a diagnosed condition that's likely to result in developmental delay, or to have atypical development. What will happen with birth to free services is there's an assessment completed by a multidisciplinary team, including physical therapy, occupational therapy, and then our staff in social emotional development and speech therapy. And the team will put together a plan. The therapists or team members then go into the family's home and really focus on teaching the parents or the caregivers the skill sets that they need to work with the child to decrease that developmental delay. Marie is here, and she's our particularly CLTS supervisor. And then children's long-term support waiver services and the Children's Community Action Program supports the need of families with a child with severe developmental, physical, or emotional disabilities. Just a few of the services that are provided under that state waiver service include assessments, respite care, supportive home care support, service coordination, and home modifications and other. Some of the funding sources include Medicaid, CPAP, rental payment, small amounts of local taxes, though those CLTS waiver services or long-term support waiver services are what we call a walkthrough of funding. So most of those services are fully funded, as well as the CPAP services or the community options program. And our comprehensive community services, so CCS as its term, is a psychosocial rehabilitation program for children and adults who have either a diagnosed mental health or substance abuse condition. And that condition impacts their functioning independently. There's a whole array of services that go into the individual's homes. And then also earlier I talked about placements. Those services can be provided in the community and adult family homes and community residential facilities or CVRFs as well. And it does reduce the need for long-term institutional placements. And it also works with individuals just to get them at their best skill level and have them have the best quality of life as possible. So we have our providers, and it'll be on the next slide, who our facilitators are. We also have approximately 70 or so individual contracted staff that provide either therapy or skill building in the community to individuals. So just listed are our CCS staff that provide service facilitation or the case management duties within health and human services. And like I said, that we have contracts for the other services. CCS is a 100% Medicaid reimbursable program. So it's definitely a preferred model of treatment both for the consumers and the agency and the community as a whole. Nice funding source to give people the services they need. You see our CCS consumer levels they stay relatively the same, although the level of services that we provide has shifted. A few years ago, we weren't set up or able to provide those psychosocial rehabilitation services in adult family homes or in those residential settings. Now we're able to do that. So the consumers haven't gone up, or the number of consumers hasn't relatively gone up too much. But the increase in services in the community has. Just a little bit more about CCS. Our CCS program is part of the Wisconsin Rivers Regional CCS Collaboration. This includes 3 counties, Sauk, Columbia, and Richland. In order to get 100% Medicaid reimbursement, I believe it was either in 2013 or 2014, the state asked that counties regionalize and have some services that they share as a region. And the type of region we're in, like I said, shares some services, but not all services. The region shares a web page. If you ever want to look at it, it's Wisconsin Rivers CCS. For those interested in CCS services and for providers that want to become CCS service providers. Michelle has been part of the regionalization process.
Question.
Yep.
Okay. This is probably the 4th or 5th program that sounds real similar. And I'm just wondering who steers people into the right one and how does that work?
Yeah, I think it can be definitely confusing for community members when they don't know where to go or what program or service to get. So I think two places, our front desk and our aging disability resource center are often the first points of contact for people just physically in our building. They will get people to behavioral health services if they see there's a need or that's appropriate. We screen daily, 3 times a week, several times a day, as we get those new referrals to get individuals to the place that they need to be. So if someone comes in and we can see at that moment they're in acute crisis, our staff will work with them as part of our crisis services programming. Someone comes in and it's like, I can wait, but I want a therapist. I want to work with therapy needs. We too actually strive to have someone call them the same day or even the next day, because you never know if they're saying one thing and maybe they need more services. So we will get them either an appointment or have a staff contact them to be sure that people are getting the correct services or going to the correct direction that they need to. Again, because Region shares a web page, we also share a database. All of the CCS service providers in the region have credentialing and paperwork that they have to do to be able to provide those services, paperwork and training. That's shared in a regional database that is housed and overseen by Richland County, actually our MIS program in Richland County has helped us set that up. Again, the regional model allows for 100% Medicaid reimbursement. That's not always been a thing offered by the state. Previously, it was a 60% coverage of that Medicaid rate we got back. But by shifting to the regional model, we get 100% Medicaid reimbursement. And the last place on the slide just has the Wisconsin Rivers CCS. And then our intoxicated drivers program. In Wisconsin, whenever someone gets either an intoxicated driver citation or criminal charge, they go through the court process and everyone has to go to their designated agency in their, so there's several steps that I tell people when they get that intoxicated driver, either citation or criminal charge. So they'll go to court, if they're convicted, they have to go to the agency in their county that's appointed to do an intoxicated driver assessment. At that assessment, there's 2 different routes depending on the outcome of the assessment. There's different scales and tools each county uses. Individuals will either go to treatment, so further substance abuse treatment, or a substance abuse education program. And they saw 73 individuals. And then also as part of our substance abuse treatment services, we provide an educational based program for youth who get underage drinking tickets. And we use the Prime for Life curriculum to provide that education to youth. And we're actually working with a couple school districts looking at providing that education and those settings as well. So. Our residential placements, talked about this a little bit in placements as well, but residential placements well for both long-term and step-down placements for clients that would not otherwise be able to live safely in a community setting. We use adult family homes that we have contracts with and community-based residential facilities. Clients are typically enrolled in either community recovery services or more often comprehensive community services. We have Medicaid as a payer source for services. The Medicaid typically provides closer to full reimbursement of those services in the CCS programming. Crisis stabilization services can be billed to either Medicaid card services or private insurances at times. to cover some funding options for crisis stabilization or step-down placements for individuals.
This is just Richland County, right?
Just Richland County.
That's a good percentage of people that are involved with this. What is our entire population, 9,000 something?
17.
So,
Or 17?
can you go back to the numbers? Like,
Boy, that's a lot of people.
that's not, that's just the number of days. That's not, there's only 12
See the
people.
clients.
Oh, I see. I was looking at the
Yeah.
number and I thought, boy, that's a lot of
That's
people.
a bit of a different number. Yeah, that's, so 12 people last year.
Never
All
mind.
of their days cumulatively was 2,900.
Yeah.
So our coordinated services team initiative is a model of care. We also use the same model of care in the comprehensive community services program. Coordinated services team started a while ago, but was really implemented in Wisconsin in the mid-1990s. It's a wraparound model of care for children with behavioral issues. It really is about teaming, working together with the child and their caregivers, teachers, community members that work with them to try to integrate services. And the goal that I was always taught with coordinated services teams is you really want that community team or those people to wrap around that child. So, our job is to eliminate really our job here at Human Services. We want the community members to be able to wrap around that child, get them to a place where they're well and integrated, and I'm gonna work to be healthy adults in society. And we want enough of those services, and I call it pouring services, and to make sure that they can be the best, most happy functioning individuals as adults. Our CST again works with children and families involved in 2 or more systems of care with complex needs. The CST model serves children enrolled in both our comprehensive community services program, and then it's also a state grant fund with a county match. So if someone is not eligible for Medicaid, they can still come work in that model and work for services. The best case scenarios is what you all probably don't hear about or see on the graphs is those children that we can pour services in, and it's just lovely to see them go off graduating as adults and having really gained a lot of benefit from programming.
I have a question about that last slide.
Yes.
So say social workers going out because there's a kid who is in a transition between, say, like a foster home or some sort of institutional setting and their biological parent. Does that social worker always go alone into that situation, or is there a team approach? Because the way that slide right there makes it sound is like that you might have more of a team approach. My experience was like the social workers seemed a little bit more on their own. So I'm just kind of wondering how you see that relationship working.
So if a child gets referred to our behavioral health unit and is enrolled in these services, we really do want a team approach or a team model. I guess it depends on the child's situation. I worked in the child protection or children's services unit, and there were statutory obligations and things that I had to do certainly in my role that unit. I think workers still would have the obligation where they might go see a child or a family alone. What we support is that teaming model to have at least monthly team meetings, if not more often, because sometimes children that might have five providers working with them, maybe 2 from mental health, a juvenile justice worker, a child welfare worker, and different teachers or individuals in the school setting. I hope that helped answer the question. Does that make sense?
Well, I'm just wondering if the social workers are on their own, or if they have, if they can have someone going with them. You know, I'm sure, I'm assuming that pretty much every child in foster care has some behavioral issues because of the situation that their family's in. So that's why I'm asking if there's a team approach, or if people in that situation I know the reason I'm asking this is I know we're having such a hard time with retention of social workers. And it just seems like that slide is, this is it's great, it's very ideal. But is it happening in practice for those social workers? And you don't have to answer it. I'm just kind of like, that's something I've been kind of thinking about, because you hear about this turnover and all these, people getting put in institutional settings. So I'm just trying to think of ways that where we can keep more of our employees and keep our costs down. And if those social workers aren't on their own, I'm thinking that could help them.
So yes, they'll be on their own at certain times. They do have like obligations to do home visits. But yes, they should be, and I know some of our staff, all of our behavioral health staff do go out in teams. And at times they go out in teams with the children's services units, but not 100% of the time.
Okay, thanks.
Sorry, detox services. So there's a couple different ways people can get detox services. When it pertains to the county human services area, detox services are mandated under chapter 5145, state chapter 5145. And the detox services that the county is responsible for include when a person is incapacitated by alcohol and in need of protective custody because they're a danger to themselves. So we do contract with a facility in Dane County to work with and take individuals to those services. It is a legal process that can be initiated solely by law enforcement and does not need Health and Human Services authorization. And then our inpatient psychiatric hospitalization stays. So this slide, this is different than Winnebago or Mendota costs. This is when an individual would be placed under emergency mental health detention because they're a danger to themselves or others. And they go to a county contracted hospital, so not Winnebago or Mendota. We have a couple contracts, Henderson and Southwest Health Center are the two primary ones. And they don't have an insurance or payer source. So that's why it says 0. It doesn't happen very often. Most people have a health insurance, often Medicaid or other payer sources to pay. And this slide is institutional placements. This would be the Winnebago costs, and once in a while Mendota costs. Institutional placements are one of the greatest liabilities for the county. Costs range between $999 to $1,400 a day. Medicaid does cover a portion for individuals under 22 years of age or over the age of 65. And Medicare and private insurance may cover some of those stays. And then services like comprehensive community services, community recovery services, and outpatient psychiatric services help avoid the need for those long-term institutional stays. And our Adult Protective Services program is designed to protect Richland County's vulnerable adults ages 18 years of age and over from treatment and circumstances that are defined as abuse, neglect, or financial exploitation. During 2021, APS responded to 61 adults at risk and elder abuse reports. Richland County gets over $10,000 annually to assist with services to persons age 60 and over and who meet abuse and neglect criteria. Adult Protective Services staff work closely with the court to assist those in need of getting guardianships. So we work very closely with our Corporation Counsel and Assistant Corporation Counsel to file those guardianships. and also do protective placement reviews of individuals and placements with our guardianship. Right now, the county has a vacancy in the full-time adult protective services position. Our two primary staff that work with adult protective services are Sean McCann. Any questions?
So weird, go ahead.
One quick question. So I didn't quite catch how far down on staffing level are you right now?
Throughout the agency, there's
Roughly.
8 staff members short. There's additional ones, but those positions are currently on hold, but 8 that need to be filled. So we're due to take a break. Do you guys want a break? Do you want to just keep rolling? There's 3 more units to.
I'm gonna have to leave because I have to get ready for a meeting tonight, so thank you. We'll see you later.
So we'll just keep rolling then. Jessica, you wanna?
I may have to leave it up at 2.
That's fine. We appreciate you guys coming.
At 4 o'clock. To a Zoom meeting.
Okay. Yeah. Okay.
So said the gear shifted speed.
It's fairly short and sweet because we covered a lot of the placement stuff earlier, which is a lot of.
Confused.
No good thing when they see it, Marty.
Thank you.
Okay.
Okay, so child and youth services. So Jimmy, if you wanna. So the staff in this unit currently are myself, I'm the manager. And actually, I screwed up and put my maiden name and not changed that. So my name is actually Jessica Tisdale. Just got married last year, so I forgot to change that. I changed everything out. Supervisor, who's sitting back here, is Britton Wirtz. She just started with us last week. That position was vacant for a period of time prior to that. So she just started on the 11th with us. Social workers currently are Brady Donahoe, Shelby Miller, Hannah Udall-Hoven, and then we do have 2 vacant social work positions at this point in time for frontline case managers. What that means at this point is that Brittany and I are both case carrying to cover some of that absence with those other 2 workers. Our youth aid worker, Eric Ives, who primarily works with our youth justice population and children over the age of 7 to do outreach and prevention services as well. And then currently we have 2 family preservation workers. Both of those are contracted positions and both are less than 28 hours per week. Cecilia Degenhart is the primary family preservation worker. And then because we've had some vacancies in the social work position and we've had additional allocations that were carried over during COVID for a funding source that funds the family preservation, we were able to also add an LTE position of Alicia Woodhouse. Alicia has only been with us for about a month and a half, but is helping us in that capacity. So the family preservation workers provide outreach and prevention services for families, as well as our supervised visitations and one-on-one parenting with families whose children are in out-of-home care or when we're trying to prevent removals. So the programs that we offer are child protective services. Frequently refer to this as CHIPS. So I put that in there just because you'll hear that phrasing a lot in different capacities within our unit. So those are children in need of protection and services. Those are formal court orders or investigations that we have ongoing for abuse and neglect allegations. We provide child welfare services. So these are services that we provide at-risk families in the community to link them up with prevention services such as behavioral health, economic support, looking for resources for child care, those types of things. We also have some funding streams that we apply for that will help to provide safety supplies in home or meet basic needs of children so that we can prevent removals. We work with the youth justice population, formerly known as juvenile justice or delinquency. Youth justice would be our children who have been referred for criminal charges. So an offense that would have created as an adult, a criminal charge is done under a juvenile statute. This also includes our JIPS cases, which means juvenile in need of protection and services. So sometimes that could be an uncontrollable teenager that a parent is struggling to manage because of the children's mental health or behavioral issues or trauma in childhood that they're re-experiencing as an older child. It could also include our truancy population as well. We provide independent living skills. We do have a regional coordinator who comes and helps us do that for any child who's in out-of-home care after the age of 14. But we do provide a lot of services for independently through our YES program. YES stands for Youth Empowerment Services, and that's a youth mentoring and outreach that we offer youth on primarily on youth justice orders. But we will also sometimes do like a YES Junior for at-risk families if we have a significant amount of younger children. Eric Ives runs the YES program primarily, and again, he serves populations from about 7 to 17, sometimes a little bit older. So if we do have a YES Junior, it would be like 17 to 12, and then our older population would be 13 to 17 or 18. We would also base participation on the youth's needs. So sometimes youth are not appropriate to be participating in this because of an offense that's happened with them. Then we would provide that on an individual basis. During that, we work on independent living skills as well as community connections, and then building positive supports with people such as law enforcement, the fire department, those types of things in our community. We also do all of our foster care and kinship licensing. So this would be licensing foster homes, outreach, kinship homes, which we don't talk about in placement, but kinship homes are a step below a foster home and they're relative placements. Richland County is actually one of the probably leading in the state in finding per capita the relative placements to work towards foster care. So we did talk about foster care earlier. Some of those people are conversions of these kinship relative placements who've been offered to become a foster home, and they're child-specific licensed foster homes. So
Kinship's just a short term until they get placed in foster?
Or it's a family member that has, so the kinship licensing process or approval process for funding, there's less funding associated to it, but it also requires less requirements of a family. So family members, it's always best practice to try to keep children with families in the community whenever possible and keep their connections. So it might be a family member who doesn't meet all of the foster care criteria because their home doesn't meet the space requirements or bedroom requirements, but they're not safety issues. So we can still place with them. Like I said,
So it could be long-term placements.
It could be, and some of those are conversions that go to guardianship later on. They're just not included in the foster care counts because they have their own funding source in a different avenue through the state. So it's just worthy to note that because we do find a lot of relative placements. We do place with a lot of relatives and they're offered to be foster care licensed, but if they don't meet the criteria for foster care licensing and they're still safe and appropriate, we will leave the children with them long term. So the placements covered by Child and Youth Services, again, we've covered a lot of this earlier. Again, the Children's Institutional Detention Center placements, so those children hospitalized under emergency detentions, again, those go through the behavioral health process. Children placed in residential care centers, used for short and long-term assessments, as well as treatment facilities for children on supervision who may have significant trauma, mental health, behavioral problems, or cognitive impairments. And then secure detention or non-secure detention as well is used for youth who have criminal charges and are a danger to themselves or others and can't safely be maintained in the community. Additional ones are the foster care, treatment, foster care, and group homes, which were in the second portion of those bar graphs that we showed earlier. So those are primarily under CHIPS orders and youth justice orders. when they can't be maintained safely in the community, and group homes are utilized for those placements that require a higher level of needs, which will be 24/7. So we do have a care and needs assessment, which is a statewide assessment that has to be done on every child who's placed in out-of-home care, which helps us determine what their level of placement should be based on their needs and strengths. Other services, we talked about kinship, so court-ordered and relative placements. There's also voluntary kinships. So the court-ordered, again, is the it's kind of like the step down from foster care, although we do allow them and do promote them to become foster care licensed if they're eligible. They qualify for additional funding sources if they're foster care licensed. It makes that kind of just a more stable placement ongoing if they meet that requirement. Again, we're not going to rule them out if there's no safety related issues. Voluntary kinship is a supportive payment to families who've taken guardianship or other long-term placement of children. So these are kids who've reached permanency through guardianship. The families continue to qualify under a different kinship funding amount that's also allocated by the state to be able to support them until their adulthood or until they graduate high school, kind of whichever is the latter of the two, up until age 19. So these children would be kids that we may have previously worked with, or they can move from another state or another county. They've taken guardianship in a private way. They'd still be eligible to receive this payment. And it does, parents are still then held liable for child support costs. There's a way to refer that through the state. Foster care licensing. Currently, I am our foster care licenser, so I'm a manager, case carrying, and our foster care licenser. So that has kind of fallen a little bit down on the list of priorities in recent, probably I would say in the recent year, as we've been down 2 to 3 staff for the past year. So we try to license and support foster parents in the community. There's a high need for this across the state, across the nation. And then again, due to the short staffing at this time, recruitment and retention efforts for foster homes just has been limited. Other services, I talked about the YES program, Youth Empowerment Services, a little bit earlier. Again, it's for mentoring for youth who are on the youth justice or other at-risk youth. It's meant to be a restorative and community service-based activities program. We work on development of independent living skills such as daily living, self-care, relationships and communication, housing and money management, work and study life, career and educational planning, and looking forward. So those are the areas we actually do what's called a Casey Life Skills Assessment when a youth enters the program, and then when they exit the program or mentoring with Eric. And our goal is to make progress in 2 of those areas over the time working with the youth at minimum. Again, we try to develop use of social skills and peer interactions and appropriate youth to adults or community members skills as well. And we do a lot of team building exercises when we're able to have a group together.
Do you do this as an individual class or do you do this as a class?
So it's been done both ways. If we have enough participants, we will do a class as long as, you know, so we've done it with a group of about 4 to 6 youth at a time where they've done community based programs. They've done some painting in the community. They've done painting up at Ada James and Passages to some of their things. They've done a couple of activities where they've raised money for the drug dog in the community and been able to put money towards an adaptive wheelchair swing at the parks and those types of things. Those are the group activities that we've done a couple of years ago. During COVID and most recently, thankfully, our numbers for youth justice have been down. So we've been doing it more on a one-on-one basis or maybe like 2 to 3 peers at a time when possible and when we're able to get those youth around the table.
Having been a high school teacher myself, I can see this as a very valuable program at the high school level to be taught you know, considering the wide variety of family types that students come from, I think something like this would be extremely useful. If you could make it short and fun and just hit the high points and get people to kind of understand and deal with this. Because a lot of parents are incapable of doing this, I think.
Well, a lot of parents haven't learned those skills themselves.
Correct. Depends on what their own backgrounds were, but
Correct.
something like this on more of a formal scale at the high school level where you can make it kind of a fun project. And I can see that as being extremely useful. So,
Yeah.
thank you.
So Families First legislation, there were some legislation changes last year in, I believe it was October of 2021. So I wanted to just briefly touch on kind of like what this legislation talked about. So it has 4 transformation priorities. So those are to strengthen local communities and build services to support families in their homes, to keep children in family settings whenever possible, to improve our group care system, and to support our workforce with solutions and improvements. So this has really come to a very, I think, a different form of social work than what a lot of people picture as child protection. So child protection, a lot of people will come and say, okay, we're gonna place a kid in foster care. We're gonna, those are the people that show up and take our children and remove them from us and create extra trauma. The Families First legislation really takes a very critical look at trying to offer supportive services to try to keep children in home and in community settings whenever possible. What it has done for our unit and a lot of other child protection units around the state is given us tools for our safety planning and our protective planning to be able to do more preventive and require us to do more prevention and outreach services. So when I talked about our family preservation workers earlier, those are fairly new positions to us that had been eliminated previously when there were budget cuts. So the state is actually providing additional grant funding allocations that we apply for on a yearly basis to support those specific positions, including our youth aid worker, as well as the 2 family preservation workers that we have currently. So our outlook is to continue to try to ask for additional allocations in those areas and maximize what we're able to do. I can tell you over the past 2 years, we've done more prevention and outreach with those workers being on staff because it alleviates those burdens of outreach and prevention services from the social workers who are trying to do the reunification efforts. The funding source also helps promote reunification efforts. So we're additionally able to, when we put a safety plan in place to keep a child in the community or to get them back into their home setting, we can pull additional targeted safety support funding in certain areas to promote additional services from those workers to provide more monitoring, more services, or increased visitations to get us to reunification when that is possible in a safe setting in the home.
So you said this legislation did also provide funding to support the extra staff effort?
Correct.
Okay.
So right now, we only have allocations for 1 part-time person, 1 person less than 28 hours per week. Because we had additional allocations the entire state was underspent last year because of COVID in that area. So we received approximately $11,000 carryover funding from that, which is how we are partially funding that LTE position, that second LTE position. So our intention would be to, when the applications for that funding source come out in September and October, would be that I would promote trying to do 2 part-time positions or 1 full-time position fully covered under those types of allocations to continue to build those prevention services and provide the support that we've been doing with our community recently. And then I just included I included the website. It's just on the Department of Children and Families website. There's some listening opportunities and some information that's on there presented by the state regarding the Families First legislation. The intention behind Families First is that they're supposed to also be getting us additional evidence-based practices and parenting curriculums that we can utilize with these families to help support reunification efforts and prevention services. So, tried to keep it short and sweet, so any other questions?
Jessica, I've got some questions.
Sure.
This is fun. Good to hear your voice. So, one question I have is for the family preservation worker that you were just talking about, the LTE position, is there tax levy money going into that? And do you need an increase in your tax levy portion to get I believe you said 2 part-time positions?
Actually, no, at this point in time, the only tax levy in the Child and Youth Services budget is through the placement funding. All other services are fully covered by the allocations and the grants that we receive and I write for.
Okay, thank you. And then let's see, my other question, it was a little bit further back. I think, okay, so I heard you say you have a caseload right now. And I think I heard, but I might need to be corrected. Someone said something about we don't have foster homes right now, or we don't have enough. And so we're having to place children in more expensive settings. Maybe I misheard that. Can you clarify or verify that?
So no, I think we do borrow homes from other counties. So our regular licensed foster homes that we're utilizing right now are either licensed by me, but they're licensed child specific for a relative only, or we utilize them for purposes of, or utilize other counties or borrow their foster homes. At this point in time, the treatment level homes that we're utilizing are due to the fact that there's either a sibling group of 3 or more, or the child has significant behavioral or emotional needs in other areas which require placement in a higher level facility. So we don't actually have any level, like any regular level foster home kids under their care and needs assessment in treatment level homes unless they're placed with a large sibling group or with a sibling who has significant behavioral needs which require a treatment level home at this time.
So do those out of county foster care placements, do they cost more to us at the county than they would if we had in-county placement options?
The only additional expense would be the drive time and the cost of transportation reimbursement that the workers receive to go to those locations.
I see. Okay. Thank you.
Any other questions? All right, we will go on to Rose.
EMT is also working on emailing all of these out to everyone.
Public health sites. As most folks are aware, public health is a service. Statutorily, there are statutes that define the operations of public health. Initially, it started under state statute 250, and that establishes the state public health system. So whatever occurs at the Department of Health Services and the Division of Public Health, that is where this entire cascade of services and programs begins. A state secretary is appointed by the governor. Right now, our health officer for the state is Paula Tran. Medical advisor for the state health officer position for our medical advisor is Dr. Ryan Westergaard. Most folks have heard quite a bit about these individuals over time, particularly with the media releases and the information that has been generated by the state of Wisconsin through the state public health system. There are 5 public health regions in Wisconsin, and then we are in the southern region. And it's a combination of counties that make up this particular geographic area, and we work together. In many cases, there are lots of similarities between particularly rural counties. You'll find that there are mutual aid agreements and consortiums that have been established between certain groups of counties, including Richland County, for certain activities.
For example, we have an environmental health coordinator who services Richland County one day every other week, although he's always available by phone or via email. He is employed by Grant County, and Grant County is the fiscal agent for that particular service. And our environmental health coordinator serves actually 5 counties. So he is on the road and he is seeing properties and meeting with individuals from 5 counties. So there are enough similarities between those 5 counties. And those are Grant, Lafayette, Iowa, Richland, and Vernon. So we serve many maybe similar types of clients and residents just because of our rural nature and the way our counties are put together. And we also have sources or mutual agreements for emergency preparedness. And those bring in Crawford County, and then also will also sometimes interact with Green. So you'll find that even though we have 5 public health regions, we also try to create agreements and try to regionalize services to whatever degree we can. Go ahead, Jamie, thank you. Our staff often rely on the expertise and knowledge of the bureaus and offices within the State Division of Public Health. We have meetings on a monthly basis with, I don't know if you've ever heard the term WALDAB, it's quite a name. It stands for the Wisconsin Association of Local Health Departments and Boards. And so we have representatives from Southern region, the health officers, and often the Board of Health members will attend the meetings on a monthly basis. And we have a representative from the Public Health Policy and Practice Alignment there. It just helps us to make sure that the policies and the practices that are occurring within local health departments, we want them to be robust. We want to provide services in accordance with best practices, and we rely on the expertise and the knowledge of those staff. We often have conversations, our nurses do, and that includes myself, with the Bureau of Communicable Disease. Not only, COVID has definitely reinforced that relationship, but we, even prior to that time, we would have conversations, and they have, it's incredible the numbers of individuals that work in the Bureau of Communicable Disease and the levels of expertise they have in every subject area. Many of these individuals are very, very experienced and very they're credentialed. I mean, oftentimes we're looking at something that's waterborne or something that may be an animal related illness. We'll have actual veterinarians who actually are there on that particular board, Communicable Disease Bureau to assist us. Community health promotion, again, we look at population-based care to whatever degree we possibly can, bringing in equity for residents within our area and making sure that our services serve a diverse group of individuals. I mentioned environmental health, but that also includes occupational health, and we have individuals in the bureaus at the state that we can rely on for that. Health informatics is as it sounds. They have information on statistics, information that's been garnered through whether it be birth certificates, death certificates, surveys that have occurred. They take a look at information on how our environment impacts public health, for example. What are we looking at for nitrates in well? Are we looking for arsenic? What are we looking at for flood prone areas? So health informatics allows us to have a quantitative approach to using a science-driven method for providing services. We know what's going on in Richland County based upon surveys and based upon information that's been generated from verifiable sources. Preparedness and emergency health care. When we think of emergency preparedness, much of that began after 9/11. We found that with 9/11, the response that occurred, particularly in New York, was disjointed and actually put rescue personnel at risk. So there was a real need on a national level to actually create a system whereby we can have checks and balances, and it can be used. It's scalable. It's called NIMS, National Incident Management System, ICS Incident Command. It's often based upon much of the protocol that you may see in the military. And oftentimes law enforcement and fire personnel have utilized this. And they're great partners with us, but public health does own a part of emergency preparedness. And when COVID actually began in earnest, the state opened up their emergency operations center, and we were actually practicing some of the preparedness techniques that we've been training for 20 years nearly. And for, gosh, almost a year and a half to 2 years, we had at first daily and then weekly and then bi-weekly emergency operations centers meetings. So it was, and we had a diverse group of local partners so that we all knew what each person was contributing, but we also were able to support them with PPE, with information that was coming up from the CDC or from the Department of Health Services, looking at industry, business, schools, and our ambulance service, emergency management, public health. We had law enforcement involved, so it was a very diverse group that we worked together in the response mode, and now I'm hoping at some point we can get into just a recovery mode, but we're still working on that. And then the Aging and Disability Resource Center was actually added to the Division of Public Health probably a couple, 3 years ago. Yeah, because of the services and the clients that they serve as well. So the ADRCs were actually brought into the Division of Public Health. Next slide, please. You'll find that 250 sort of starts, chapter 250 or state statute 250 kind of starts the process by establishing the state public health system. Chapter 251 establishes local health departments. We take a lot of our marching orders from chapter 251. It establishes the system of local health departments. Of course, there can be variations on that theme. You'll find that some are freestanding. You'll find that there are combinations. If we look at public health, Madison-Dade County, that's a city-county linkage. In Washington and Ozaukee counties, they're actually a combination of 2 counties who have banded together to create services based upon public health practices. Chapter 251 also establishes boards of health. It actually talks about the numbers of individuals who can be in a board of health, and it also describes those variances, those varieties of boards of health. Some are freestanding boards of health that just serve a health department. We have a health and human services model whereby our health and human services board actually acts as our board of health, and they weigh in on issues of public health interest, and they vote on those particular situations. They also promote policy and procedure development and things of that sort. And now that we have our health and human services board veteran standing committee, there's been just a slight nuance in that particular board of health appearance as well. We have 11 members on our health and human services board veteran standing committee, but only 9 of those individuals are able to act in a capacity to support public health as an actual board of health. And as I move through the chapters, 252 is specific to communicable diseases. It establishes immunization programs. In some instances, it actually calls out certain communicable diseases by name, such as tuberculosis, HIV. There is a small mention of meningococcal and hepatitis B, but the statutory law actually gives us guidance on how to approach those and what our health officer and a local health department's responsibilities are in following up on communicable diseases, from leading investigations to ensuring the overall safety of individuals in our jurisdiction. In the legal challenges that have occurred in Wisconsin, there's been an awful lot of comments made on Chapter 252. Just recently, when the Supreme Court allowed Public Health Madison-Dade County to have the decision that their health officer made to allow for forbidding gatherings and for masking and the like, they quoted actually 25206, which indicates that health officers are charged with responsibility of doing whatever is necessary to suppress the transmission of communicable diseases. So we've heard an awful lot about that. Chapter 253, as it reads, involves maternal and child health services, everything from prenatal care that can be offered to an individual before a baby is born, to care that occurs postpartum, And then it actually runs the entire gamut of services. It includes the WIC program, but it also includes language on abortion under that particular statute. It doesn't, public health doesn't usually assume a great role in that, although reproductive health care services can be provided at public health agencies. We don't are involved in that. There are different levels of care that can be provided. There are level 1 local health departments. There are level 2 and level 3. You'll often find in some of the larger municipalities, particularly those who are level 3 facilities, they may offer some reproductive health care services. So there's lots of language under 253 on childcare and services to support parents and families. 254 is specific on environmental health. Our environmental health coordinator works a lot on human health hazards. For example, for dirty houses or people of garbage or things outside. If the environment inside or outside creates a human health hazard, whether it be a vector for vermin or rodents, or whether or not it is an area that can create issues with mosquito development, or just cause a safety hazard to individuals in the home, then he can issue orders or work with individuals to abate that so that we're trying to create the safest environment possible. He also works on childhood-led investigations. He'll actually go on site if necessary, pull samples of paint, sometimes varnish. You don't see that very much anymore. Interior and out and exterior as well, because paint that is chipped off into soil can be dangerous for children. He actually helps to work with homeowners to mitigate those particular needs. And not only does he identify areas where lead may be present, but also once abatement or mitigation activities are done, he goes in and actually performs a clearance test to make sure that all the work that has been done has been successful in mitigating that lead risk. He also works with private well testing to look at the quality of water, works with radon testing as well. And then I believe he also is our environmental health coordinator, is actually able to go and particularly help fire departments when they're looking at possible asbestos and things of that sort. Although asbestos in the environment, I think, is more of a DNR activity. And then chapter 255 is chronic disease and injuries. We're looking at preventing cancer, heart disease, diabetes, and those long-term illnesses that can definitely impact individuals and their families and the community. But we also look at injuries. How can we prevent falls? How can we look at other preventable injuries such as motor vehicle accidents and things of that sort? And next slide, please. In public health here in Richland County, we do get federal block grant funding. Often it's called categorical because there's a specific amount of money that's provided for emergency preparedness, or for communicable disease, or for maternal child health, and each category is allowed some money. It's not a lot, I'll be completely honest. When we have the opportunity, we do write for grants, although that's been a difficult process for a while. Being able to research, write for, implement, and evaluate a project or activity that's grant funded is a long and sometimes involved process. So we have,
Does that fall on you, or do you get help with that?
grant writing. I have written some grants on my own, although I think the last time I did it, I was working at the EDRC. I actually have been around locations in Richland County. We have had, my predecessor actually was able to write for a grant, but that's been a while back. And we did have a community health educator here for a while who actually did work on writing grants and things of that sort. I can do that. Sometimes it's just the time right now. Because
It does sound like there's a lot of opportunity though.
there are opportunities, but they're typically all competitive. It just depends on, but once you write for a grant, you really need to have an infrastructure to roll out a new project or a plan. And it's time limited. Some grants can be fairly lucrative, but if they are, the level of involvement and need and evaluation is substantial. The problem with that too is that the money is soft. It's here and gone. And it's difficult sometimes to retain personnel if they know they're only going to be here limited term basis, and their ability to actually have benefits is minimal as well. So that's what makes comparative grants a little bit of, it can make it kind of difficult. They're wonderful to get, but they're short term, and it's tough to retain your staff based upon that type of money.
Okay.
We have limited revenue streams. We sell our flu vaccine, you know, I do order some privately, and then when folks come in, we do bill their insurance for that. We provide TB skin tests and other very limited income streams. We try to make it affordable for individuals or for employers to have their staff come here and get certain types of services. Maternal child health, we can bill for that if the person has medical assistance, although we don't see very many individuals who are referred to us, at least not lately, are those who will allow us to stop by. Folks tend to have lots of spheres of influence, and sometimes they would rather rely on their friends or family for advice on raising children. I think so. We provide information to them. We send out birth packets to every parent who has a child here in Richland County, so they've got information on the services we provide, child care seats, immunizations, and things of that sort. We always offer home visits with every package that we provide. So I know questions, we're all for the ones to tailor the information to them, whether they're interested in safety practices, anything that works. We do whatever we can, at least in a field form, to give folks some tools to help them be established as a parent. And then tax levy dollars do make our department whole. And we will fairly large amount of tax levy. However, statutorily, it says that counties will support local health departments. So there is language that indicates that when counties establish a local health department, they are also responsible for something. So that is something that is there. Next slide, please. For public health nurses, I'll go through it quickly. There is actually baseline expectations for levels of education for public health nurses. And under Administrative Code 139, it actually says that any individual who is working as a public health nurse needs to have a bachelor's degree. However, because it's been so difficult for us to recruit and retain nurses that have that level of qualification, we were able to create a public nurse clinic position in 2020. That was permitted an RN without a bachelor's degree to practice in a public health setting under the supervision of that prepared.
How do you feel about that?
Excuse me?
How do you feel about that?
Well, I tell you, in a perfect world, it'd be great to have everyone at a baseline level. However, the caliber of nurse that we were able to recruit is incredible. She is absolutely amazing, and she just works like you would not believe. She just moves ahead all the time, open to suggestions and for programming, and she's been a godsend. She's able to give us unbelievable support. So we've been very fortunate. Public health nurses need to engage in communicable disease control and prevention. We do an awful lot of that every day. We look more now toward population-based care, just because we are able to have a larger impact if we're able to implement services on a larger scale. When we would meet individually and make home visits with individuals, we were able to see one or two folks, and perhaps we would be able to bring the greatest amount of information and support to them. But if we're able to take that service and apply it to a larger group of folks, we're hoping that the impact will be much greater. So we now have to look at maybe population-based care rather than just one or two individuals that we'd see in a home care setting. We still see people in their homes, and we love doing that because there's nothing that can replace that interaction with someone. We look at assessment of the services we provide and how successful it is. We assure that the services that we are providing are best practices and also in accordance with statutory law as well as administrative code. And then we base policy development on that, both having that quantitative and qualitative information, and then assuring that the services we're providing is where it needs to be. And then we do, prior to COVID, we did a little bit more of this, but we really try to educate communities providing information so that they can be healthier and safer at all levels. Next slide, please. I mentioned our sanitarian, he's also known as our environmental health coordinator. He needs a health related degree and he is licensed as a sanitarian. We're fortunate that he's been engaged in his position for 18 and 19 years, so he's very well experienced in his role. And actually his supervisor at Richland County is a sanitarian as well. So he actually has an individual that he can actually consult with too if there are any questions or concerns. So he's been doing it a long time. He's well known. He's actually someone who's lived in Grant County himself, so he knows the clients that we know as well, because there's so many similarities between the populations that live in rural Wisconsin. He, again, coordinates those health programs I mentioned, the human health hazards, the radon, the water quality, and then also like the human health hazards, things of that sort. And as I mentioned, it is a contracted position. We're part of a consortium with 4 other counties. He's in Richland County one full day every other week. And then we actually allocate some of our prevention block grant funds to Grant County as the fiscal agent. So that, and then also we provide another small amount of money through Richland County to help support his position. So, but all the counties in that consortium do the same. Next slide, please. We do not have a current health educator here at Richland County Public Health. We have had the benefit of having health educators in the past, and they sure bring an awful lot of knowledge, insight, and efficacy to the role. Typically, they are educated with a community health education degree. They're often certified health education specialists. If you've seen the CHES designation behind someone's name, it indicates that they are certified as a certified health education specialist, and that takes some time and effort to get that. They work extensively in areas such as chronic disease control, tobacco control, prevention programs to bring us as a group or as a population to a higher level of health. Our most recent health educator was very active in our community health needs assessment, our community health improvement plan. I just spoke to our finance and personnel committee, services board, and veterans data committee on securing the services of a consultant to assist us with that process. It's statutorily defined that public health departments engage in this process every 5 years. And it's a really large process. Right now, we're looking at least a 9-month period of time during which we're collecting information from vetted sources, that quantitative data, health rankings, our environmental health tracking. We're looking at what our youth have stated as far as their substance use and things of that sort. It's called a YRBS, or risk behavior survey. And then we're going to be surveying the community, hoping to get a really diverse group and a large group of folks to weigh in on how they feel about their experiences personally and what they see the county needing for services. Once we have that information, then we'll have focus groups to speak to people individually. You see that maybe we have these 5 big topic areas. Let's flesh those out and see what are the top 3 areas that we really need to work on, because that will actually define our strategic plan and tell us what we need to be working on for at least the next 5 years.
So that's done every 5 years?
It is.
So there's a current one right now?
We are actually in a holding pattern with that community health improvement plan and health needs assessment that was completed in 2016 and extended in 2021 is still in place as a placeholder. We're in the process of collecting data right now.
Right, but how does one access it, see it?
It is actually on our Richland County website.
Okay.
If you go on the website, you can drill down and get to health and human services and the public health, and you'll actually see, we can click on those.
Okay.
Both the health assessment and the improvement plan are both there, and those are published for folks to see.
Okay.
And our health educators have typically been grant funded. We have seldom had the ability to maintain a permanent presence for them just based upon the funding that we've had. And that makes their positions a little bit tenuous. They're here for a while, but then once our grant funding leaves, then they typically go with that funding once it's gone. Next slide, please. And again, this is our programming primarily. Disease, health, environmental. We do have specific adult health activities as well. prenatal care coordination, emergency preparedness, and senior nutrition. We actually do have our senior nutrition program that is a unit underneath public health. Let's go with immunization for communicable disease, patient follow-up, tuberculosis prevention and control, again, by doing our TB skin tests, that helps us perhaps identify on occasion folks who may be not actively infected necessarily with tuberculosis, but those who've been exposed and may have a latent case of TB, but those individuals do need to be treated to prevent that potential latent condition from becoming active. We are very busy with disease prevention. Any type of animal bite that occurs, there's very specific state statutes on that as well. And law enforcement is our partner in that. So if there is an individual who seeks care at a local healthcare provider, it's identified that that person has been bitten, whether it be a domestic animal like a cat or dog, or even perhaps by a wild animal. We've actually seen some things where people have become involved with a rodent like a woodchuck or a muskrat or things of that sort. Law enforcement is called to those, to the ER, and that's typically where folks are seen, and then they complete an animal bite form. Public health gets it, and we begin the process of investigating that, ensuring that there's quarantine for the animals involved and that they're seen by veterinarians.
So you must work with the hospital a lot to get all this information.
Some of it, yeah, it depends, yeah. Especially for communicable disease investigation. We often rely on infection prevention nurses, and whether it be the Richland Hospital or other hospitals, they tend to have those records that we need to access. Sometimes we have enough information from the laboratory results that we see that come into our state system, but oftentimes we rely a lot on facilities, especially infection control, because they have that information for us. And then our unit is also responsible for providing bloodborne pathogens training. We do that for the drivers, for the ADRC. We actually have provided it to our staff here as well, and can provide it to other groups if necessary, but we let folks know about that. Next slide, please. As I mentioned, we can see prospective parents before their babies are born, and actually prenatal care coordination is a separate freestanding program through which the public health can be reimbursed, and we were quite active in that before. The amounts of money we get is small, it's Medicaid rate only. However, it's been difficult for local health departments to provide it as easily as we did before, and I'll tell you why. There are big concerns in recent years about there being some fraud in some areas of the state, that perhaps there was some issues with billing. We've never had that here, because I used to actually do quite a bit of prenatal care coordination. But health officers, if we're going to be providing and billing for this particular service under Wisconsin or Maine, we need to be fingerprinted. There needs to be ongoing surveillance. We've always been quality improvement, quality reviews of our charts, but it's become a much more enforced practice. So we're more than willing to provide prenatal care services, but billing for them, maybe not so much. So folks are always eligible for them through all 3 trimesters of their pregnancy, and then for up to 60 days after. And then again, we're very happy to provide postpartum home visits. We often get referrals from hospitals. We used to get them from WIC, but WIC isn't seeing folks in person as much as they had been prior to the pandemic. So yeah, we still are wanting to provide services, although we don't see that many people being referred to us anymore. Next slide, please. I mentioned environmental health and the services that Troy Morris is our environmental health coordinator. So that's a lot of what he does. Next slide, please. Adult health, we didn't really bring that out, but we are part of a consortium for Wisconsin Rural Women Program Services. Juneau County actually is our fiscal agent or consortium lead, and one of their health educators works specifically in the Wisconsin Rural Women Program. We also work with, I know at our free clinic in particular, we have a patient navigator for the University of Wisconsin hospitals who actually comes and specifically works with individuals who are eligible to enroll in the Wisconsin Rural Women Program, and can get them actually pretty much set up for eligibility there on the spot, and then also assist them with making appointments and making sure that their healthcare needs are being taken care of. We continue to have a loan closet here. I don't know if you folks are familiar with that, that particular program. A loan closet allows us to have pieces of medical equipment. We're looking at walkers, wheelchairs, canes, and other crutches, things of that sort, that we can loan out to individuals. People pay a very small fee. It can be as low as $1. And I think the highest amount that we charge for any 6-month period of time for a piece of equipment is $10. So it's low cost and it's meant to support individuals so that they can remain as independent in their home and as safe as they can in their homes and the public. And then again, we make public health home visits to folks of all ages, but again, we serve adults in that regard as well. So please. The bottom of the preparedness, and I mentioned how a lot of the events that occurred on 9/11 actually promoted there being kind of a wide need to educate folks and to have them work on the same plane as far as preparedness goes. But we do practice and train for preparedness and response every year. And when COVID came, we were actually practicing it in a real life situation. So we would get, we were providing vaccines like at the community center 1 to 2 days a week early on when vaccines for COVID were first released. We were seeing hundreds of people. So we were actually implementing and practicing on mass clinic plans. And we still have pandemic influenza plans, although it's kind of more because COVID is quite an influenza virus, although it is respiratory in nature, but some of those influenza plans are still still good placeholders because of the work that we do to support our response. Again, we have local and regional exercises. I know some of the funding we get mandates that we participate in a regional exercise every year. Again, sometimes it's been that's something that we do, and we work together. There's always a different topic for us to practice every year, whether it be volunteer management or fatality management or things of that sort. And so those are things that we do every year, and actually we've been implementing these in real life for the past few years. So next slide, please. As I mentioned, the senior nutrition program is actually embedded in public health. Senior nutrition began through a 1965 decree of the Older Americans Act. It actually put this particular kind of act. So I'm going to actually maybe refer, I misspeak, I'll have you correct me, because many senior nutrition programs are actually embedded in aging disability resource centers, whereas it's slightly different in that regard. But the funding, and the lady who actually is most aware of that actually is our ADC, our AD, let's just say the aging disability resource manager. I talked too fast. There is federal funding that is administered through the state of Wisconsin. And then you see that GWAR, the Greater Wisconsin Area Agency Resources, actually does help administer some of those federal dollars, if I'm correct in that regard. Right now, our seniors, those who are 60 and over, and for certain folks that have been qualified for a waiver, they can be under the age of 60, they have a special need. But usually folks that are 60 and over, just by virtue of their age, actually qualify for the senior nutrition program. So we do have congregate meal sites where people can get together and eat, and it helps them to socialize and become involved together in the community.
You don't have to be 60, there's no other means, that's it.
Yeah.
Really?
Yeah.
Yeah, I only got 3 months to go.
I've been missing out.
Yes, and again, it's usually a donation based, so you donate when you can. So that's something that really helps people, and it actually provides 1/3 of an individual's nutritional needs. So by getting the meal that you get, it's already been identified that you're getting 1/3 of your nutritional requirements through one of the meals that are provided. So again, for those that aren't able to come to our meal sites, or those who perhaps prefer not to, they are eligible for home delivered meals, and we do a lot of meals. And also we've offered a grab and go option, particularly during COVID. When folks, we transitioned from hot meals that were home delivered and those that were provided in a congregate setting. when we couldn't have folks assembled. And so when we switched everyone to the frozen option, not everyone was that crazy about that. So knowing that there would be minimal interactions between those who were providing the food and those who were recipients of the food, some folks chose to go with the grab and go meal, and that allowed them to go to the campus where the meals are provided. There was like a circle there, and they would actually have like in a carry-out container, they'd have a hot meal that was prepared for them. It was the same menu as that that everyone would receive, and they could just go through, pick up that meal, it would be placed in their vehicle, and they'd have a hot meal available to them. It was offered 3 days per week. It's been very, very popular, and folks are continuing to access that particular service. It allows them minimal interaction in case there are concerns about health, but it allows them to have a hot meal that's been freshly prepared at the campus that same day. And right now during the summer, we're actually implementing a rise and dine option for folks who want to come in on a Wednesday, 1 day a week. It's for 12 weeks. They can have a freshly prepared, made to order breakfast meal for them. There's a rotating menu, and it's, I mean, we're looking at eggs Benedict, blueberry pancakes, and things of that sort. So it's also very healthy. And we're actually serving another group of individuals who tend to prefer that type of a meal option. So that allows us to serve a larger group of folks. And then our senior farmers market nutrition program is one where folks who are age and income eligible are able to get up to $25 of vouchers that they can utilize to buy locally grown fruits, vegetables, herbs, and things of that sort. They're often distributed at the farmers market, so folks can actually sign up, receive their vouchers, and actually go and purchase some of the food that's already been provided at the farmers market. So very popular, very busy program. And then the value of prevention. This is a little bit dated, but it indicates that for every dollar spent on early childhood health and development, $9 is saved in the future when we have to look at spending on other types of health, social, and justice services. The return on investment for some of the time that we spend with families, particularly with children, is 800%. We look at immunizations. That program saves $10 for every dollar spent when we are able to bring immunizations to children to help keep them safe. Prevention is always a big one. We know how much money that can be spent in healthcare if people are negatively affected, if they begin to smoke or use other types of nicotine or tobacco. But we can save $20 for every dollar spent on the prevention in tobacco. Again, I have to almost say nicotine now because there are so many delivery methods. Not everyone smokes anymore. It's not just regular tobacco. Oftentimes nicotine is pretty much your vapes, things of that sort. So that's a 1,500% investment. In prevention services, preventing chronic diseases, preventing illnesses, preventing the spread of a communicable disease. Every time we spend $10 over the course of a person's over a 2-year period, we actually save $2 billion. When we're looking at it over a large group of population. So a lot of what we do is prevent illnesses and disabilities before they start. Next slide. If you have any questions, I'm happy to. I know this was quick, but I know we're getting to the end of the long day.
I have no questions. I can't stay though. I need to go.
We have one more left.
Thank you, though. Thank you for your time and patience with me.
We'll have Roxanne talk.
I'll talk fast. I'm used to that, actually. Every time we do one of these, I'm usually at the end and I got about 2 seconds. So it's okay.
I just wrote a note that we're gonna switch the order next year.
So. So our Aging and Disability Resource Center is part of a 4-county region which serves Richland, Sauk, Juneau, and Crawford. And so what we do is we connect Richland County residents and their families to the resources they need. So our vision is we're focused on customer service, we're welcoming to all, we're a trusted source of information, assistance, and advocacy. We're responsive to the unique needs of each consumer, and we're highly visible in the community. I have some abbreviations, and so anytime I talk about the ADRC, I use these abbreviations, and then people ask me what does that mean? So I just listed those.
our INA is our information assistant, EBS is our elder benefit specialist, DBS is our disability benefit specialist, FC stands for family care, IRIS is include, respect, ISO direct, and MCO is a managed care organization. So who we serve, basically we serve any people from 17 and a half up. So we serve aging adults that are 60 plus, adults with physical disabilities that are 18 to 59, adults with developmental disabilities that are 18 to 59, adults with mental health or substance abuse disabilities as well, 18 and above actually. Youth with disabilities transitioning to adult services, 17 and a half. This is one of those areas where we work with the children's unit to transition students that are either, maybe they're working with child youth services or they're working with the children's long-term support program, and they may be in placement sometimes. This is where we work with those students to help transition them to adult services, which then they go into a program called Family Care or IRIS that can then pay for placements or pay for the services that they need. So then that, in essence, if we have a large placement right now for an individual, he'll be aging out next year. So when that individual ages out, we'll get them connected with family care so that it isn't a draw on any kind of tax levy. So that's for our youth in transition, that is things that we do. So we have our county employed staff. We've got 8 full-time staff and 1 part-time staff, which includes myself, our elder benefit specialist, disability benefit specialist. We have 3 information and assistant specialists. We have transportation secretary. We have our receptionist and then a part-time clerical assistants. Plus we have 4 temporary casual drivers who drive our bus. And then we have 23 volunteer driver escorts. Funding for the EDRC, and this is a nice place to talk about that because we have 2 different programs, or we have many programs, but we have our aging services and we have our EDRC services. So our EDRC services we don't have any tax levy for EDRC services. We receive what's called a general purpose revenue grant through the state of Wisconsin. And then we also get federal match for any of those services that we provide that are Medicaid related. So all of our ADRC specific services, we don't have any tax levy. As far as our aging services, that would be our elder benefit specialist and our transportation program. And then we have what's called National Family Caregivers funding as well. Those types of programs, we have a required match. So we pay, we get funding through the Greater Wisconsin Agency on Aging Resources, but then there's a required match that we have to provide. So that's how we pay for services within the ADRC. So things that we do with that money is we have our information assistance specialists. So they meet with individuals and assess what they're needing in order to stay as independent as possible and remain in their own home. Our goal is always to help people age in place and remain vibrant members of our community. So we also do then with them, they do options counseling, they do transition services for our youth. They do the initial assessment and enrollment into family care. So that would be assisting people with applying for Medicaid and then doing what's called a long-term care functional screen. And then from there, we have our benefit specialist programs. So we have our disability benefit specialist program, which works with individuals who are 18 to 59, and our elder benefit specialist program that works with adults over 60. We have transportation program. We do health promotion activities as well. Those we contract out with Simon's Recreation, who then does our health promotion programs such as Tai Chi, stepping on, and let's see, strong bodies. Going so fast, my brain isn't keeping up. We also have a dementia care specialist program, and then we have caregiver programs as well.
Curious of the people you serve, how many directly contact you versus neighbors or relatives contacting you versus other parts of HHS?
You know, it's a really big split. Generally though, anybody that we work with, it's a voluntary service. So if we have a neighbor that contacts us, they'll say, oh, my neighbor is needing, you know, need somebody to come in and help them with services. We always ask them if the neighbor is aware that they're calling for them, and to make sure that before we contact them, it's okay that we contact them. So it's really a mix between individuals and their family members. We do work very closely with the other units here within the building. But because it's a voluntary service, we always have to get consent from them that they even want to talk to us.
Right.
Yeah, so I can't really give you probably a split, it's kind of hard, it's a, you know, I would say the majority is the individual calling this themselves, so, yeah. Another thing just to be mindful of is return on investment. So aging and disability resource centers across the state. So if you look at that starburst in the middle, for every dollar invested into Wisconsin ADRCs, it leads to a savings of $2.48. So statewide, we have a 248% return on investment. For our local office for 2021, ours was 456%. So for every dollar that was invested into our local ADRC, there was a savings of $4.56. That could be a savings to the consumer, that could be to the county, that could be savings to the state. It's that return on investment dollars. So if you look at prevention, there's ADRCs prevent 61 hospital readmissions per 1,000 served and 101 emergency room visits per 1,000 served. So if you think about it in that term, then it's nearly $1 million per 1,000 served that is saved across the state. We can go on, Jamie. So looking at our individual ADRC, so we actually reached 2,600 citizens received our information assistance services for a total of 4,565 contacts in 2021. That's down from 2019 due to COVID, but that's, I think, pre-COVID, we were just over 5,700, I believe. We enrolled 94 members into long-term care programming. So that could be family care or IRIS, the IRIS program. Another thing to note about that is when you have individuals that maybe are in Winnebago for mental health reasons, a lot of times we work with individuals that are dual diagnosed. They've got mental health issues, plus they've got physical or cognitive issues. So we work with them to see if they qualify for family care. And then that family care funding can actually then become a funding source. So we work very closely with behavioral health. We worked with schools assisting 5 families transitioning their youth into adult services. We assisted 147 residents with disabilities to receive benefits of $590,073. So in the DBS position, our disability benefit specialist position was open for 3 months. So that wasn't even a full year.
What exactly are the benefits?
So that could be them receiving, receiving disability, supplemental security income. It could be Medicare Part D, like their drug plans. Could also be food share. Could be helping them with appeals. You know, a wide variety. And we get that number directly from the state. So they actually have a system where they enter in all of their clients, the services that they have been approved for, or the funding that they've been approved for, and then it spits the number back out to us. And then our provided benefit counseling and advocacy to 333 senior residents, saving over receiving benefits of $1.448 million. So our elder benefit specialist does our Medicare Part D every fall, and so does our DBS as well. But of course, most people are over 65 that are getting Medicare Part D drug plans. And so we see a huge influx and huge savings for a lot of our seniors. In Richland County, most of our seniors, if you look at the average amount of income that they have, is about $1,200 a month. That's what they're living at. So the services that Joanne provides, and for our disability benefit specialist, Kayla, as well, that, you know, if they can save you $50 a month, that's a huge savings to them. You know, that can be the difference between whether or not they're, you know, eating meals or getting their medications. So that is an extremely important service that we provide here. So also provided, we provided 3,319 one-way medical appointment trips.
We have our volunteer drivers provided 6,180 service hours, driving over 134,000 miles. Our wheelchair trips, we provided 709 wheelchair trips, providing 18,249 miles. We provided 19 families with caregiver support funding for respite and in-home services. We participated in providing education and support to enroll seniors in the Senior Farmers Market Voucher Program. We conducted 5 Medicare education workshops. We restarted those mid-year last year due to COVID. And then we partner with, like I said before, Assignments Recreation to provide Tai Chi and Strong Bodies health promotion classes. So program funding again, our ADRC programs, we get ADRC general purpose revenue grant plus our federal match. So there's no tax levy in those core ADRC programs. Our aging programs, the Greater Wisconsin Agency on Aging Resources, we received $254,664 in revenue, but that does require a match of tax levy. Our transportation volunteer driver program and our bus program, we receive the 8521 grant every year, which is $79,889. That again also requires a 20% levy. And then we also apply for the 5310 grant, which varies on how much the award is, and that is for our bus programs. The nice thing about our 5310 grant is we can use our 8521 funding, that grant that we're pretty much guaranteed every year for our driver escort program. We can use that as our match. So we can use tax levy or in-kind match for that 5310 grant, and we actually use the 8521 as our match. So partnerships, the ADRC is, partners with a lot of different entities. This is just a list of a few of them. I won't really go into them since you're going to get this emailed to you anyway. So in the interest of time, I won't go through them all. And then we can go on. And then you'll see us around the county. We're very involved in a lot of different things throughout the county, outreach events, making sure that people are getting the resources and the information about resources that they need. And then we're here for you. So contact us whenever you need information and assistance in finding services for yourself, your family, or friends. Consider using our options counseling service when planning future long-term care, needs. Contact us before you need us. So we always say know us before you need us. And then we also simplify Medicare and other benefits. And then one of your constituents appears to be at risk for abuse and neglect, please contact us as well. And then board members are always invited to tour the ADRC or just contact me because I know that we kind of flew through this really quick.
I've been holding off questions,
You can find out there.
and I don't think I'll take a tour right now.
Okay,
because I
that's
do
fine.
leave.
Yeah, you're welcome to stop.
Oh, we gotta get out of here.
I know what the things you gotta do before.
And then you gotta come back?
Yeah.
Okay.
7 o'clock?
Yeah.
Do you mind if I ask a couple of questions?
That would be great.
Okay, so one, I'm wondering, do we provide any money to seniors to help them stay in their homes? I saw that state statute, we were looking at those in the past week. Melissa Luck and I were, and that's an optional thing that we can provide. Do we do that with levy money or with other money?
No, we don't.
Okay. And then is the senior meal site, is that under ADRC or was that under public health? I think I missed that.
Yeah, so that's under public health. Most of the nutrition programs across the state are under the ADRCs, but in our county, it is under public health. It's kind of a strange setup. So Rose does the programmatic and then I do the fiscal side of the nutrition program. So I do all the claiming and make sure that the funding sources are all there, all of that good stuff.
It's not the first time it's
We'll see you later. Thank you for
Yeah,
coming.
thank you.
Oh, wait for a minute for me.
Yeah, I had to let it back in earlier. I've let him in like 3 times.
Oh,
It's just that it's like.
I hear chickens.
it's in the out towards.
He did write a little chat
West
about
Lima.
it
Yeah.
for the chicken rice.
Is that where he lives about that West Lima?
I'm not sure.
I think he's on that, right? Yes. I'll go to 24 if you want to. 20 months? It's usually not the first month. Oh, that's right.
And was it the last week when we had the night meeting between the state and person?
Is it just totally
I know.
screwed right now?